On behalf of the AAAS, welcome to the Judicial webinar on emerging issues in neuroscience. It is the latest in a series of similar events over many years, although in previous years, these events were in-person seminars, whereby the American Association for the Advancement of Science offered judges around the United States the latest information on neuroscience issues. Now, thanks to a generous donation from the Dana Foundation, we have the pleasure and honor of offering you, in cooperation with the National Center for State Courts, today's program, which I'll describe in more detail momentarily. But first, let me ask you to please excuse any audiovisual quirks that may occur during this, our first webinar for judges. But we trust you will find this program both interesting and very helpful. And let me, on behalf of AAAS, thank you in advance for your interest and participation. Now, today's program will have four main components. And that is, we will start with Dr. White, who will discuss the brain. He'll provide an introduction to the brain. And then we'll have Dr. Claw, who will discuss the neuroscience of pain. Then we will have Dr. Stark talk to us about memory and the brain. And then finally, we will have Dr. Cicciarone discuss the brain and addiction, and in particular, the opioid crisis, which I'm sure, unfortunately, many of you are having to deal with in your courts. Well, with that, as my father used to say before I'd go to school in the mornings, learn lots, and allow me to turn it over to Margaret Allen Hoyt of the NCSC. Thank you.
Great, thank you very much, Alan. I'm just going to share my screen and I'm going to share a couple of things with you before we get started. It's such a pleasure for us at the National Center for State Courts to partner with AAAS to bring this education opportunity to judges across the country. I have just a few Zoom items to walk through before we get started. But I do want to talk about a couple of different partners. You may have learned about this webinar from a judicial educator in your state. We reached out to the National Association of State Judicial Educators to let their states, let their state's judges know that this opportunity was coming up. Of course, their daily role is to bring continuing education to judges and non-judicial court personnel all around the country. And so we thank our partners at NASJA for doing that. We also reached out to the American Judges Association, the National Association for Presiding Judges and Court Executive Officers, NAPCO. And we're just so pleased to have you all here. So with that, I will walk through a few Zoom items. So you are seeing an email, which I'm going to ask them to put in the chat as well. We don't expect this to happen, but sometimes it does happen. Folks get dropped from the Zoom room. If you do and you need help getting back on, you can send a message to Jordan Schwartzbach, who will be glad to help you. He's also available for help via the chat. You see him listed there as AAAS Tech Support. So he'll be right there should you need anything. Then just a quick reminder, you'll have your camera off and your mic off. Should you need to stand up and stretch, that's great. Feel free. And just like the movies, you can have a snack if you prefer. And we're going to ask you to, as I mentioned, keep your microphone and webcam off. If you do have a chat, you can go ahead and use that for questions and answers. And then we will insert those when faculty pause and take a breath or at the latest at the end of their presentation. All right. So I just mentioned, send us a chat if you have any questions or comments. If you just need to step away and fill up your coffee cup, no need to reach out for that reason. And now, even though we are all in the middle of our postgraduate work with our knowledge of Zoom and other similar platforms, I'm just going to go through a couple of things. You see the toolbar labeled at the bottom with A, B, C, D, and E. Just a reminder, you'll click the microphone button to mute or unmute yourself. Likewise with the stop the video icon there. You'll click that to turn on and off your webcam. I do encourage you to click on the participant icon. That'll let you see a list of everyone who's here. You may see a colleague that you haven't crossed paths with in some time. And same thing with the chat. I encourage you to keep that window open so you can see questions and comments that others are sharing. Then finally, reactions. We'll get to that in just a moment, so you can kind of give some nonverbal feedback during the session. And so when you click on the reactions button, this little screen will pop up, and I'll first draw your attention to raise hand at the bottom of the box there, not to be confused with the diagonal hands at the top left of the box, and that is applause. So if we welcome you to put your comments and questions in chat, but you may also raise your hand and we'll check in with you and see what you need. Otherwise, as you're so moved, you can clap, give a thumbs up, laugh, be surprised, give a heart or a celebration icon as desired. Just a quick note on the chat there. I just click on that chat icon to see what others are contributing to the session. And should you want to save the chat, sometimes there's some great links and resources that are shared. So you can just simply click on the three dots to the left, or excuse me, on my other left, on the right-hand side of that box, and that'll save it to your desktop, or not to your desktop, in your documents folder. It'll create a Zoom subfolder. Okay, now annotation. So you'll go up to the top and you can click on the view options. You'll see annotate. And so I'm going to throw you a curveball, ask you to do that right now, to click on that view options, then annotate. Then you're going to click on stamp, and you will have a choice of a star, a heart, etc. And so once you've done that, I would like you to stamp. Let's see here. And I'm going to punt because I'm not seeing the annotate option. I'm not on my own screen there. So we know that you are coming from all over the country, and that's another reason we're excited to bring you together today for the session. And I'll check in with Jordan and see if we can get that working for a little bit later. Okay, you will be going to breakout rooms after each session to discuss the content a little bit more. And should you have any questions, there's a call for assistance button. You can call that, and the faculty or Alan or myself or Joel will come in and see if we can help you. You'll see a countdown timer start when you're about to come back to the main room. You can either come back right away or just wait for the countdown timer to count down. And then if you are going to report out, just kind of spread the wealth, let folks take turns doing that if you could. And now we're back to Jordan's slide. I am going to let our first speaker pull up their slides and give the floor back to Alain, who is going to introduce our first speaker. And before Alain starts, I'm going to fully introduce myself. I am Margaret Allen Hoyt. I am from the Institute for Court Management at the National Center for State Courts. We offer certification programs for court managers, and please know that judges are always welcome. We'd love to see you in class. So with that, Alain, I'll let you go ahead and make that introduction, and the other slides can be pulled up.
Hello. Good morning again, or good afternoon, depending on where you are. This is Alain Norman again. With AAAS. Wanted to welcome everybody who has now joined us, in case a few people missed it. Thank you very much, Margaret, for that very thorough presentation. The bottom line is, in general, please stay muted and perhaps even turn your camera off. But if you do have a problem, just write to me or to Jordan, and we'll help you as best we can. Also, questions can be put in the chat, and they will be dealt with, for the most part, if they're substantive, at the end. Otherwise, we'll reply in the chat about them. Well, it is now my very great pleasure and honor to introduce Dr. Leonard White. Dr. White is at the Duke Institute for Brain Sciences And basically, he is a recognized expert in the structure of the human brain. And his primary interest has been to try to understand the maturation of neural circuits in the cerebral cortex, which is already far beyond anything I comprehend. So that is excellent for him to come to us today and provide his presentation. Dr. White is also a co-author and co-editor of a major textbook on neuroscience, and he directs courses for medical students and undergraduates at Duke University, and he leads workshops on the structure and function of the human brain, and he'll be letting us know more about that momentarily. Dr. White, over to you, and thank you.
Thank you very much, Alon, and thank you all for being here. It's really a privilege to share this time with you and to have the opportunity to serve you in whatever capacity I may be able to do so this afternoon. When Alon first asked me to speak to you, providing an overview of the human brain, it occurred to me that given our presence in a virtual webinar, I could think about that differently than I would if we were gathering out of town with limited resource. So what I wanted to do with this time in the next 30 minutes or so is to actually show you some human brain specimens. And for that reason, I'm here in a teaching lab at Duke University. I apologize if there's a bit of an echo in the sound. We've got a lot of hard walls around us, but this is the space where I would get out human brains and demonstrate them to learners at all levels here in the university. And it's my privilege to be able to do that with all of you. So I do want to give you that fair warning that I do intend to show you actual human brain specimens. And I realize there are various sensitivities around that experience. And some of you may wish to step out for the next 30 or 40 minutes or so. That's perfectly fine as far as I'm concerned. I would also invite any of you who have questions to feel free to follow Margaret's direction of raising your hand with the hand raise function, put a question in the chat, or simply unmute yourself and interrupt. And I've asked Jordan and others monitoring our session today to help me pay attention to those features of Zoom, since my attention will probably be with the brain specimens, and I trust all of you. So with that said, before I get the first specimen that I want to show you, I do want to let you know where these specimens come from. We do not purchase body parts, and we do not purchase whole cadavers. Rather, we run an anatomical gifts program where individuals and their loved ones voluntarily register with our School of Medicine with the intention of making the gift of their physical remains their last act, if you will. And this takes tremendous courage, tremendous hope, and tremendous faith and trust in our capacity to honor their wishes and to fulfill their wishes. And so what I'm doing with you today is the culmination of a long process by which their physical remains were received, were processed, and eventually were dissected, because that, after all, was the intention of the donation. Dissected by our students, and now their human brain has been curated and preserved in the collection that I maintain here at the Duke University School of Medicine. So I did want you to know that we will be looking at actual human brain specimens, but what we will do today is entirely consistent with the intentions of those courageous individuals and their loved ones who made this gift possible. Okay, so always like to just acknowledge those facts as we get into a human brain. So I believe that Jordan has pinned the view that I will use this camera to demonstrate, or he will change that. Thank you, Jordan. And I'll grab the first specimen I want to show you. So what I am going to show you first is actually the entire central nervous system, which includes the brain plus the spinal cord. And we've removed this from a cadaver through very meticulous and careful dissection. And here we are. There's the spinal cord. And here is the brain, and I'm going to make some adjustments with my camera controller so you all can see this as well as possible. So I'm holding in my hand the brain, and it continues in through what would be the base of the skull into the vertebral column as the brainstem and then the spinal cord. So this is one continuous structure, and this constitutes, as we say, the central nervous system. The peripheral nervous system includes the extensions from the spinal cord and the brain that grow out into the body as nerves. We can see some example of that here at the very bottom of the spinal cord in this collection of nerve roots, which I will try to enlarge for you all to see more clearly. So these nerve roots run down through the sacral region of our vertebral column and then out to innervate muscles and sensory tissues throughout the lower part of the body. These are often the nerve roots that some of us struggle with as a source of pain should there be a bulging disc, for example, in our lumbar spine. But these would be elements that would now represent the peripheral divisions of the nervous system, basically the nerves that run out to the body. We also see along the side of the spinal cord these little knobs that emerge about every 2 to 3 centimeters along the length of the spinal cord. These are called dorsal root ganglia. They contain the sensory cell bodies of the nerve cells that grow out their connections into the spinal nerves, innervating the body. So these receive the signals from the body about pain, about touch, about motion, about movement. Okay, now you're probably wondering, what is this tissue that's covering the spinal cord? The entire central nervous system is surrounded by layers of tissues. What you can see most obviously is the outermost and thickest of these tissues. This is called the dura mater, one of my favorite words in all of neuroanatomy. In fact, if I can show you the brain, and I will back off a bit so you can see things more clearly. I still have that tissue surrounding the brain. This is the dura mater. This is wonderfully named the tough mother. That's what dura mater means. The tough mother, or the durable mother that surrounds and protects the brain. Underneath this tissue, we have other additional layers of covering that we're actually looking through now to see the surface of the human brain. And we can talk more about that later if you wish. This is relevant for brain injury and trauma and stroke, where there may be accumulations of blood in the brain or between some layers of these tissues. Some of you, for example, undoubtedly know about subdural hematoma. That would be a collection of blood underneath this dura mater. So I'll just show you a few additional features and then we'll move on to a different specimen. Here we're looking at the underneath side of the human brain, and I'll try to focus on that just a bit more. And this allows me to highlight a few additional parts of the brain. We have beneath the large part of the brain called the cerebrum, the brain stem, and this is a transitional part of the brain where the spinal cord becomes a continuation down into our neck and throughout our vertebral column. Just behind the brain stem is a wonderful part of the brain called the cerebellum. And I'll say a bit more about that in just a few minutes. But I like to think of the cerebellum as the part of the brain from which our agility arises. And by agility, I have in mind both the smooth and efficient and accurate and precise movements of the body, but also the movements of the mind and even the movements of the emotion. You're probably also noticing some of these darker structures that are running along the surface of the brain. These are blood vessels. We're looking here at some of the most important vessels that supply this more lower part of the brain, including the brainstem and the cerebellum. And the blood supply to the brain, of course, is critical. We cannot survive for very long at all with any compromise to that blood supply, and regions of the brain can be damaged through blockage or rupture of these vessels. That's what produces stroke. And lastly, I'll point out a few other kinds of extensions that you may notice from the brain. For example, right here, these are the optic nerves. These are the connections from the brain out to the eyes and specifically to the retina, where neural processing begins to create visual images in the form of electrical signals that are communicated through these nerves into the brain for more full processing. Here's another obvious nerve out here on the lateral aspect of the lower brainstem. This is called the vestibular cochlear nerve. That's the nerve that processes and transmits signals related to hearing and balance. And lastly, right in this position, we have a nerve called the trigeminal nerve, which conveys signals about pain and touch from the face into the brain. Well, we don't have time to go into much more detail than that for this particular specimen, but I do want to move on and show you an additional several specimens with a focus on the largest part of the human brain, the cerebral hemispheres. So I'll transition from this specimen to my next. Bear with me as I just step aside and grab the next specimen. So now we have a brain which I have partially dissected. And that partial dissection is to remove those outer coverings so that now we can look and see the cerebral hemispheres. So I say hemispheres because, as I suspect you all appreciate, the brain comes in two halves. That is most obvious here in this cerebrum, this largest, most forward part of the human brain. So as we're looking, that is the left hemisphere, and this is the right hemisphere. The front of the brain is here, the back of the brain there. And in this particular specimen, I've removed the brainstem and the cerebellum so that we can appreciate the fact that the cerebral hemispheres continue onto the underside of the brain and even along the midline of the brain, which is otherwise connected one hemisphere to the next through a large bundle of connections that I'll show you in yet a different specimen. But just to give you a quick run through the various parts of this cerebral hemisphere. Again, we have a right hemisphere and a left hemisphere. Each of these hemispheres is formed by an outer layer of tissue called the cerebral cortex. And what we're seeing here is the folding of that cortex. And each one of these folds has special names. It's not important that we identify them for you here, but they're roughly spatially distributed, and we have various terms that we apply to describe the larger formations that we can appreciate. And those I do want to name and identify for you. So here to the front of the brain, underneath my hand, this is where we would find the frontal lobes. So there are two frontal lobes, one in each hemisphere. And the frontal lobes are one of the largest divisions of our cerebral hemisphere, basically from this boundary where I have the stick placed forward, that is the frontal lobe. The frontal lobe includes our motor cortex, which is localized right about here. That motor cortex is what generates the command signals that convey the intention of our movement down to the spinal cord and ultimately relayed out to our muscles. But then the rest of this frontal lobe is what we often associate with executive functioning or executive control. In fact, we have an odd term for this part of the frontal lobe. We call this the prefrontal cortex. prefrontal is an odd expression. It's the front of the front, or the part that's in front of the front. And we call this prefrontal because it's in front of, or it's anterior to the motor cortex. And this is the part of the human brain that arguably is most evolved, is most expanded, and is most unique to the actual structure and function of the human brain. Okay, with respect then to this frontal lobe, I like to think of the frontal lobe as being oriented towards the future. The immediate future in terms of what are we about to do with our bodies. That's where the motor cortex comes in, but also the more distant future. That's where this executive control system, localized largely to this prefrontal cortex, comes in as we think about our plans for the future, our future behaviors, both in the near and in the long term. Okay, gross simplification for sure, but that just gives you a sense of what's happening here in the frontal lobe. Behind the frontal lobe is a region roughly about in this part of the hemisphere. This is called the parietal lobe. Incidentally, these terms for the lobes are named for the bones that overlie them. So we have a frontal bone and a parietal bone here. And the parietal lobe is largely about receiving signals derived from our body and also situating those signals in the world around us as informed largely by our visual system and our auditory system. And this parietal lobe takes that information and generates, as we say, an image or a scheme of our body relative to itself and the spaces around us. And that scheme is very important in planning our movements and directing our attention within that space. Okay, parietal lobe here just behind the frontal lobe. Near the back of the brain, we have the occipital lobe. And this is the most posterior portion of this cerebral cortex that's involved in vision and visualization. These regions extend onto the lower or inferior part of the human brain. So this occipital lobe is also greatly expanded because for most of us, barring some kind of malformation in early development or perhaps because of injury, we're highly visual in our behaviors. And the brain has evolved extensive circuitry to process the signals derived from our visual pathways that begin in our eyes. But this part of the brain is not just for processing the signals from our eyes. It truly is about visualization, which includes the imagery we see in our mind that might even be discordant or otherwise not the same as the actual images projected into our eyes. Okay, so that leaves us then with this part of the human brain, which is on the lower and lateral part of the brain. Sometimes we think of the cerebral hemisphere as if it were a hand or a mitten, and the thumb is overlying this part of the brain that we call the temporal lobe. Again, temporal because the temporal bone is overlying this part of the brain. And this is arguably the most complex part of the brain, just in terms of all the various functions that are going on here. There are language centers here that are receiving language signals in the form of speech and written text. There are auditory systems that process the sounds that we hear, be they speech or otherwise. There are extensive visual pathways that are helping us encode what it is that we're actually looking at. Is it a face? And if it's a face, whose face is it? And there are intriguing systems right along the inside edge of this temporal lobe that are involved in processing memory and processing emotion, particularly emotion that triggers vigilance and the ways in which we respond to social cues. Okay, so just a few last points about this specimen before we move on. Each of these cerebral hemispheres has this outer cortex, as I mentioned, but there is also a set of structures deep into the brain that I want to show you by looking at slabs of a different brain that have followed dissection through the cerebral hemisphere. So the cortex is on the outside. Cortex is a great word. It means bark, like the bark of a tree, just the outer layer of cortex. So there's a lot going on inside the brain that I want to show you as well. But the cerebral cortex is what we're looking at here from the outside, and it is acknowledged by most anatomists to be the, well, one of the supreme achievements of mammalian evolution, and giving us the capacities for behavior that are so relevant to all of our lives. Now, within each hemisphere, that cerebral cortex is roughly the size of a medium pizza dough. So if I were to unfold and remove the right hemisphere and the left hemisphere and flatten it out, it'd be about 13 inches across. So that gives you a sense of how much tissue is actually folded up into this specimen. Okay, so I'm going to make another change of specimen here. So bear with me just a moment. And here I have three slabs, I should say, from one specimen. And they are cut in the plane of the face so that we can see a few structures that I think might be relevant for some of the other speakers that are going to talk to you this afternoon. So I'm going to try to make some adjustments here and direct our camera appropriately. So this slab here at the top of my tray, and I realize there's some glare and my autofocus will try to catch up here. There is a set of structures deep in the hemisphere called the basal ganglia. And among them is a region that is right about there. And I'll put a few sticks sort of pointing to it from either direction. So that structure is in a part of the basal ganglia that we recognize as the nucleus accumbens. And this is a fascinating part of the brain because it seems to sit at the interface between emotion and movement or motivation for behavior. And arguably, we might think of this as something of a ground zero for addiction and addictive behaviors, because virtually every known substance or experience to which human cultures have ever become addicted, have ever abused, seems to modify the signals that are processed in this part of the brain. So that's called the nucleus accumbens. We may hear more about that later in the afternoon. There are other brain circuits and other neurochemicals involved, of course, but many of them converge in this part of the brain. Okay, moving on to our next section. This middle of our specimens here contains a set of really fascinating brain structures that are found deep into the temporal lobe. So again, I realize there's glare and maybe I shouldn't try to push my ability to focus too far here. Let's just see if that comes in. But I do want to highlight a mass of gray matter that is found right here in the temporal lobe. We see it best here on the left side. This is a mass of brain tissue called the amygdala. And the amygdala is that part of the temporal lobe that's receiving signals that can increase our state of vigilance. Now, that's sort of the, the hopeful view of the amygdala. If those signals are too strong, that vigilance can become anxiety or even fear. If those signals are too weak, then perhaps we are at some risk. That is, we may not be reading the signals from our environment and from the social cues in our immediate context that might otherwise be best met with preparing the body for some action. So perhaps the heart rate will increase a bit, the breathing will increase in its depth, and our blood pressure might rise. The distribution of blood in our body might favor our musculoskeletal system, allowing us perhaps to quicken our pace if we happen to be on a walk on a dark alley somewhere. However, this part of the brain also seems to be a place where those vigilant signals can emanate when we might think it's not so important for that to happen. Indeed, this is a part of the brain from which we think signals are derived that give rise to implicit bias, prejudice, and even blatant dehumanization. And so this is a part of the brain that is richly connected to other brain structures, including that prefrontal cortex, where we think there are networks that can mitigate the influence of this structure. So we all have an amygdala. The amygdala is a very powerful part of the brain, but I think there is significant variation in what we do with the signals that are coming from this part of the brain. Some of us, I like to think all of us here, are successful mitigators of the influence of these signals that might lead us towards biased or prejudicial judgments, particularly of other individuals. But as we know, there's lots of individuals that may struggle somewhat in that domain, and perhaps the education that is mediated by plasticity in these parts of the brain, including that prefrontal cortex and maybe even the amygdala itself, might give us opportunity to mitigate some of the bias that we struggle with in society. Now, lastly, the final slab that I want to show you includes a really wonderful part of the brain just behind the amygdala. It's again here in the temporal lobe. It's called the hippocampus. The hippocampus is located right here. Another great word in human brain anatomy. It means the seahorse or the sea monster. And that hippocampus is a place where memories are being made. So all of what is constituting the right here and the right now for each of us is passing into our hippocampi. We have one in each hemisphere. And from that neural processing and the plasticity that's happening at the synaptic and circuit level, we are making memories. Okay, I know we have a session on memory later today, so you'll learn much more about it then. One last specimen to show you today. And this is a specimen that I have sectioned right down the middle so that we can see some of the structures that are present right along the middle of the human brain. And I will just grab one hemisphere at a time to show you that. Okay, so this is a section that I have made to separate the two cerebral hemispheres. Let's get a little focus going here, okay? So here is the cerebral cortex folding into this midline separation between the hemisphere. The hemispheres are connected by this massive bundle of connections called axons. This is the corpus callosum. Above, and all of that sits above the brainstem and the cerebellum. Now, between the brainstem and the cerebral hemisphere is an intermediate part of the brain, which includes the hypothalamus, found right here, and the thalamus, found right there. The hypothalamus is helping to mediate the signals derived from the cerebral cortex and the physiological systems throughout the body. The thalamus is receiving signals from the special sensory systems, from the spinal cord, and is engaging with the cerebral cortex to trigger the onset of behaviors of all sorts. So that's one cerebral hemisphere, the left hemisphere of this particular brain, and here is the right. So obviously it looks very similar. It's not identical, but very similar. Now, I also wanted to show you this particular brain because this individual in life experienced serious, significant neurological disease and injury. It's not so evident here looking at the midline of the brain. But if I take this left hemisphere and turn it around, I think you can see, even without having any prior expertise in this topic, that there's a lot more space between some of these gyri, as we call them, or convolutions or folds in this specimen, as we saw in the previous one. This is consistent with this person having significant progression into Alzheimer's disease. Now, I don't know the medical diagnosis definitively, because that would require a microscopic examination of this tissue, but the distribution of degeneration of the cerebral cortex would be consistent with Alzheimer's disease. But there was more to this person's story, which I can infer from examining the brain. If I look at the right hemisphere, what we see is even more severe degeneration. And this is precisely in a pattern that would be consistent with a stroke involving occlusion of the internal carotid artery on the right-hand side. So this is what can happen in life when there is significant degeneration or significant compromise to the supply of blood to the brain. Now, I just want to conclude by giving you one last glimpse at the brain that I spent some time on, showing the cerebral hemispheres. And that is this particular specimen, just so that you can appreciate something of the contrast between what appears to be a quite healthy brain and one that has undergone significant neurological injury. Now, it may surprise you to know that this exemplary brain that I was showing you is actually from an individual who died when they were 101 years old. And this is one of the, if I may say, one of the best representations of a human brain that I've encountered in my work here at the university. So, you know, there's much that we have to learn, much that we have to continue to research, continue to pursue. But let me stop here at that point and just allow our organizers to transition to what might come next, be it the breakout rooms directly or any question you may have.
Thank you, Dr. White, for that very enlightening discussion and presentation. I hope that my brain at 101 looks as good. It probably doesn't right now. Yes, thank you for the applause, reactions. Anybody else want to put those in? That would be wonderful as well. I am not aware of any particular questions that have arrived via chat, but if I may, since I'm here, I'll take advantage of being sort of the host. So, you know, towards the end there, Doctor, you were showing sort of a very healthy, almost ideal, I suppose, brain in terms of physical characteristics versus a few that had shown various sorts of neurological or maybe physical damage that had somehow been done. Have you all been able in your lab, or do you study sort of the various, if you will, patterns of damage? And are you able at all to relate them to certain manifestations or pathologies that one would have seen in life, or that perhaps led to the demise of the person? Over.
Yes, thanks for that question. So this is really classic neurology. I spend a good part of my professional life teaching medical students and neurology residents. And one of our goals in teaching brain science and brain anatomy is to allow these physicians, really all kinds of healthcare providers need this knowledge, to create a mental model in their mind of the integrity of the brain and the spinal cord and the nerves based on their understanding of the anatomy, so that when they see someone who may have weakness on the lower right side of the face, weakness in the right arm, but they're able to walk, and that person may have some language problems, our future clinicians will know immediately, oh, that sounds like a problem in the lateral aspect of the left hemisphere. Maybe if there was sudden onset, there was a stroke. And indeed, I know exactly what blood vessel might have led to that condition. So I have to remind our learners that neurology pre-existed radiology and magnetic resonance imaging and all the marvelous technologies we have to examine the human brain. We can just learn the basics of brain structure and function and be careful observers of other human beings. Putting that knowledge together, one can, as we say, localize injury within the nervous system based on assimilating this information. Now, there's a wonderful place, of course, for brain imaging in today's technology and healthcare world, but it's often to confirm what we already surmise based on the integration of our knowledge.
And indeed, you're way ahead of me, and I see a question coming in. I've looked a little bit from a lawyer's point of view at the question of neuroimaging. I know that as far back, for example, as the Hinckley case, when he was being prosecuted, his defense entered a CAT scan, as it then was, to try to suggest that there was some sort of damage, I gather, to his actual brain that then would mitigate in some fashion his responsibility there. So if you're a clinician and you think you see, as you say, somebody with a bit of a slack situation here or certain movements that are perhaps more difficult, does one normally then move on to neuroimaging, be it functional or not, to confirm that these days? Over?
Yes, that is common clinical practice. I think probably it's done routinely now as just a way of gathering the evidence that a clinician needs to support their decision making. But in many cases, I might say most cases, it's really not essential that the physical examination, the history that's taken through interviewing the person when that's possible. It's not always possible to do an interview depending upon the injury or the condition of the person, but that information gets you very, very close to where we want to be. And the brain imaging really just confirms and reveals additional details that we wouldn't otherwise have. That's often how it goes. If a person is doing brain imaging because they don't know what parts of the nervous system are injured, that's probably not an experienced or well-educated clinician. I do want to respond to Judge Hemmert's question, if I may.
Please.
So thank you so much for that. The relationship we have with the donors is completely anonymous, and we have no further contact with the families of the loved ones. So we do learn a lot about an individual's brain, and we can infer aspects of their life and their experience of their neurological selves, but we do not communicate that back to those families. And the contracts that are written, create that kind of distance, which I think is a very healthy one. I would say, though, that at the end of the year, we do hold a memorial service led by our students who did the dissection work, and we do invite the families to come. So again, we protect the anonymity of the donation, so the family would not be asking about a particular individual's remains, but we do want to express our gratitude in a meaningful and personal way.
Well, that's very, thank you. Thank you, that's very good to know. One sort of question, and I don't want to preempt what a judge may ask, but to what extent, if any, so far, do things like neurology or neuroimaging, in your opinion, how would are they helpful, perhaps in a courtroom setting, in helping people assess, obviously this would be in the case of a living person, their mental capabilities, or and I know some of it becomes a philosophical debate, or are there distinctions to be made between a physical difference or situation and what one might call, the mind, in your view? Thank you.
Yes, thanks for that. So my answer to that is probably going to be different from, let's say, a neurologist or a neurosurgeon who may be asked the same question. I'm a neuroscientist, and I am in a tradition of individuals who feel like we are only beginning to understand the structure and function of the human brain. Maybe a century from now, our technology will advance to the point where we can actually produce with the kind of technological support that one would want in a court of law to make fine distinctions about structure and functional relationships between an individual's brain and their behavior, past, present, or future. I don't think we're there yet for many, many cases. In the instance of fairly gross, and I mean that in terms of large scale abnormalities or injuries or afflictions, yes, these current imaging methods are sufficient to gain some insight into the function and integrity of many parts of the brain. But if we're trying to assess finer details and relate them to behaviors or actual episodes in life or actual acts committed, I think we have to be extraordinarily cautious because the technology, in my opinion, just does not yet support making very strong judgments about the relationship between fine brain structure and human behavior.
I really appreciate your views on that. That's very important. And I think many people watching and listening today will have that in the back of their minds, wondering how far down the road we've gone, if at all, because it looks like science is advancing in leaps and bounds, but it does sound like caution is and humility is still appropriate. Would anybody else like to add questions in the chat or raise their hands for Dr. White? Well, one other sort of maybe more specific to you, Doctor, and your lab and the center there, Duke. What are your next research projects or goals? Based on what you've already done, and what do you think are the new frontiers, so to speak, that you'd like to explore in this area? Well, thanks.
Yeah, thanks for that question. I mean, here at Duke, we have a broad range of research, and I'm sure all the other speakers today would say the same about their institutions. And there's a lot of reason to be hopeful and optimistic about the future as our knowledge of the brain begins to really transform the lives of people and the way we come to think and understand human society, both in terms of health and wellness, but also in terms of optimizing function at the individual level, at the community level. So I think we're in a very exciting time in neuroscience as we learn more about the brain. I'll just highlight a few examples. On the medical side, we're seeing really remarkable opportunity, I think, to intervene on some of the most serious and significant of all medical diagnoses. The glioblastoma, for example, which is one of the most aggressive types of brain tumor. Here at Duke, we have a brain tumor center that's really pursuing some remarkably innovative approaches to trying to capture the tools of our immune system and turn them against brain cancers of various sorts. So that's very exciting to see. On other fronts, we're seeing the integration of technology into the human brain, sometimes at a very low-tech level, sometimes a very high-tech level, involving the implantation of electrodes that can be used to deliver electrical impulses that might recreate sensory experiences, such as cochlear implants or retinal prostheses, or even direct implantations into the cerebral cortex itself. We're also seeing opportunities to harvest signals from the human brain and use them in various ways, such as to direct computer operated systems, including things like exoskeletons for individuals with spinal cord injury to enable them to walk again. Some of that work is happening here at Duke. But I think more broadly, we are advancing to a place where we're beginning to understand how to take advantage of the brain's intrinsic capacity for change. I've used this word plasticity a few times today. So this is an extremely active and exciting area of neuroscience where we're understanding how our experiences in life, including our education, as broadly as we want to think about that term, can actually reshape the structure and function of circuits in the brain. And that potential can be used for all manner of benefit to individuals and to society. It can help with the rehabilitation of individuals following injury. It can help to improve our theoretical and practical approaches to learning across the lifespan. And it can help us come up with a deeper understanding of how to mitigate some of the destructive forces we find in society today, including things like political polarization and the impact of bias and prejudice. It's a wonderful time to be a brain scientist and to be optimistic about the future.
Well, thank you very much, Dr. White. I believe we're going to take a break now in terms of putting people into breakout rooms for a bit of a discussion before we turn to Dr. Claw, who's already here with us and waiting. I believe that Jordan, our IT expert, will put people randomly into breakout rooms where you can discuss what Dr. White has presented. And if you wish to pursue some of your questions, I see one that just popped in. Then perhaps we can have Dr. White join your particular breakout group. And if you don't mind, Doctor, hopping around between groups, that would be awesome. So we're moving to the breakout session now. Thank you.
Thank you so very much. That was fascinating. Yeah. It was
really great. The live demo worked so well.
Right? Yeah.
Thank you. I'm glad you thought so on your end.
And the big sort of reveal, and it's like, oh, and look here, we have stroke damage. Yeah.
Well, that's one of the benefits for me anyway, of going through this last year as a university educator. I've sort of had to learn how to use some of this technology for this purpose.
Yeah, but it's the silver lining of it and I mean, now also you've probably already done this, hit record on your end on a few of these. So yeah, you get to
inflammatory drugs, acetaminophen, that these are all drugs that actually only work well in about 1 out of 3 individuals we give them to. Opioids are not recommended for use in osteoarthritis or for most types of chronic pain anymore. And even joint replacement surgery, when you take out a knee that's damaged and put in a brand new knee, 20 to 30% of the time will fail to improve an individual's pain. So why is that? Why is there such a bad relationship between what we see in the periphery and what someone's experiencing with respect to pain? And this is an analogy I started using 15 or 20 years or so ago to explain pain to patients, but it works for non-patients as well. And that is that the amount of pain that someone is experiencing is analogous to the loudness of an electric guitar. And there's 2 ways you can make an electric guitar louder. You can either strum the strings harder, or you can turn up the amplifier. And if we superimpose those 2 knees that I showed you earlier, and then I show you the rest of the central nervous system that Dr. White so eloquently showed you, we have nerves that begin in regions like the knees, different types of sensory nerves that pick up heat, cold, chemical signals. And when those nerves depolarize, that information from the sensory nerves goes up through the spinal cord. And eventually, if it makes its way all the way up to the brain, it can be felt as pain. We have brain regions that tell us where the pain is, how intense the pain is, how we should behave or move in response to pain. But one of the things that we've learned about in the last couple of decades is the central nervous system exerts very powerful influences over these signals that are coming from the periphery. There are pathways that come from the brain downward that inhibit the upward transmission of this information. There are other pathways that come from the brain that facilitate transmission. So the brain can, to a significant extent, control the amplifier setting here and determine which of the signals coming in from an area like the knee, or any area for that matter, are allowed to go up to the brain to be felt as pain, and which of them are inhibited such that that information is not allowed to go up to the brain to be felt as pain. Because remember, pain should have an adaptive function and make us move away from something that is hurting us. But obviously it would be maladaptive if every time you moved or every time you sat in a chair, you were experiencing pain. So what we now are beginning to understand is that if you want to try to figure out whether someone has pain or not, you have to interrogate both what's going on out in the periphery by doing something like a X-ray or an MRI of the area of the body where the person's experiencing pain. But you also then have to estimate, is this someone who has a high amplifier setting that's had a lot of pain over the course of their lifetime, and maybe they're experiencing pain really fundamentally because of an amplifier problem rather than a guitar problem, that a lot of pain conditions we're realizing, and I'll talk about fibromyalgia being the poster child for this, the pain is entirely coming from the brain and is entirely an amplifier problem. It's not a problem out in the periphery at all. And so fibromyalgia, there's a lot of things that we got wrong about fibromyalgia initially, including counting tender points and finding how tender people are. But a more contemporary view of fibromyalgia in the last 5 to 10 years is that virtually anyone that does pain research believes not just that fibromyalgia is a very real entity, but that it's the poster child for a third mechanism of pain that used to be called central sensitization or centralized pain. Now there's a new word that's a mouthful called nociplastic pain. But in these pain conditions, individuals don't have anything wrong out in the areas of the body where they're experiencing pain. We can't identify any damage or inflammation that would be accounting for this pain. It really seems to be driven largely or entirely by what's going on in the central nervous system. And these individuals have a lot more than just pain. They have hyper-responsiveness to other types of sensory stimuli other than pain. So not only do they have pain, they find lights to be brighter, noises to be louder, odors to be more bothersome, but they have other symptoms that come from the central nervous system, like fatigue, memory problems, and sleep disturbances that are part of this constellation or this syndrome as well that we call nociplastic pain. So individual we label as having fibromyalgia with sleep problems, memory problems, fatigue, and often mood disturbances, again, are sort of the tip of the iceberg. And what we're realizing that conditions are really where there are regional forms of fibromyalgia that are just presenting in different areas of the body. And so a new term that is being used is chronic overlapping pain conditions. And here are some of the conditions that are now acknowledged to be really very similar, if not identical, to fibromyalgia, except in many of these instances, the pain, at least the presenting complaint, is in a single area of the body. So headache is obviously head pain, irritable bowel is pain in the abdominal region, temporal mandibular joint disorder is facial pain, interstitial cystitis is bladder pain. But you see, over the millennia, we've identified these different terms and labels for pain in an area of the body that we can't otherwise explain or understand. And what we're now realizing is that all of these conditions really seem to be the same underlying problem, is that this increased amplifier setting in the central nervous system causing not just pain, but some of these other CNS symptoms that also commonly co-occur. And we see that these same mechanisms that are front and center in conditions like fibromyalgia also play a prominent role in conditions that start out where the pain is due to some damage or inflammation. So for example, cell disease, from when they start having sickling crises when they're infants, that pain when they're an infant will be the kind of pain inflammation, what we call nociceptive. But by the time that person becomes an adult, their pain usually has morphed into being much more fibromyalgia-like pain. But one of the real problems with this kind of pain is this kind of pain does not respond to opioids. In fact, opioids often will make this kind of pain worse. And this kind of pain, intuitively, you would understand if it's not coming from the peripheral areas of the body, it doesn't respond to injections or surgical procedures. So we see a lot of people with conditions like low back pain or endometriosis over-treated with surgery or injections into the back, or hysterectomies to remove the endometrial tissue. And a high percentage of those surgical procedures will fail to relieve pain because that's not where the pain is coming from. The pain is coming really from the central nervous system. And so this is one of the recent reviews on this new construct of nociplastic pain. It was published in Lancet, but again, it's pain plus fatigue, sleep, memory, and mood problems. And again, sensitivity to other types of sensory stimuli, not just painful stimuli, highly suggesting that this is a central nervous system problem. Because again, if you remember what Dr. White showed you, that pain or sensory information from the periphery, like he showed you some of the nerves down at the bottom of the spine come in through the spinal tract, but information from the optic nerve, from the eye, or from, he pointed out the trigeminal nerve that brings sensory information from the face, those nerves go directly into the brain. And so if someone has increased sensitivity to smell and odors, as well as an increased sensitivity to pain, this is almost certainly a central nervous system phenomena that seems to be driving this process. And so we have these two mechanisms of pain that we've known about for a long time: nociceptive pain, which is pain that is due to damage or inflammation, or nerve pain. You have a pinched nerve like sciatica or carpal tunnel syndrome. And again, Dr. White showed you how easily those nerves that come out of the bottom of the spine could be pinched by a bulging disc, or by degenerative joint disease as someone gets more elderly. But this mechanism of pain, of centralized or nociplastic pain, has only really been sort of codified and accepted within the last 10 to 20 years. And so people with conditions like fibromyalgia, irritable bowel, headaches, often have not gotten the appropriate treatment. Sometimes physicians or other providers don't believe there's anything wrong with them at all, that they're just making this up, because they were taught that you should see pain on the x-ray, or there should be some damage or inflammation, or at least nerve problem, in order for someone to be experiencing chronic pain. We now know that one of the most useful tools to give someone that has chronic pain is a tool like this, where you ask them to fill out and how widespread the pain is, how many different areas of the body that someone has pain in at the time you see them, but even more so, how many different areas of the body someone has pain in over their lifetime, is a great measure of what someone's volume control setting is. Because almost all individuals that I might see with a condition like fibromyalgia at age 30, 35, 40, started out in childhood or their teens with irritable bowel syndrome, headaches, painful menstrual periods, back pain. They went to subspecialists that were in charge of those different areas of the body, were told there was nothing really wrong with them, you just have a benign pain condition, but yet there's nothing at all benign about having a condition like fibromyalgia. These are very disabling conditions, even though there's nothing wrong on blood tests, there's nothing wrong on x-rays, there's nothing wrong on structural MRIs. I will show you that functional MRIs, there's a lot wrong. There's a lot wrong functionally in these nociplastic pain states. But again, to screen for whether someone has this kind of pain, we look at how widespread the pain is by how many different regions they check on a body map. And then we also ask them about fatigue, memory problems, and sleep disturbance. And given how severe this is, this can be scored from 0 to 3 for each of these symptoms. And we actually come up with a numerical score for the degree of fibromyalgia that people have. If someone has a score of 13 or greater, they are said to have the condition fibromyalgia. But we don't really think, and most pain researchers don't think, that this measure should be used like that. It should be really used as a measure to say, the higher you score in this measure, the more of your pain is coming from the central nervous system rather than from a problem, for example, in the knee. and you're going to have to use treatments that are aimed more at the central nervous system than in the periphery to try to make that kind of pain better. And again, a point of emphasis is that treatments like opioids that can be quite effective in treating acute pain due to a surgical procedure are quite ineffective in treating this kind of pain, widespread pain, fibromyalgia-like pain, where more often than not, you'll make the person worse instead of better by giving them a drug like an opioid. This is just sort of showing you that if someone comes in to see me with knee pain and they have just pain in one knee, that's an entirely different person than someone that comes in with knee pain, but they fill out a body map like this and say that they really have pain in a lot of areas of the body, or they have had pain in a lot of areas of the body. Their chief complaint might be the knee. But again, if I focus too much on the knee, I'll lose the forest in the twigs and not realize that this is a classic sort of nociplastic pain patient that I'm going to have to use an entirely different set of treatments than I'm going to be able to use for someone with purely nociceptive pain. So again, the individuals that we label as having fibromyalgia are the tip of the iceberg. The same kind of pain occurs very commonly in low back pain, in sickle cell disease, and even in conditions like rheumatoid arthritis or lupus, where again, there is clearly ongoing damage or inflammation, but this process can be superimposed upon this. This is another article that came out recently that I was involved in, just talking about central sensitization in chronic pain conditions like rheumatoid arthritis or lupus or sickle cell disease, and just showing how the degree of central sensitization or nociplastic pain markedly predicts what's going to work and what's not going to work with respect to treatments when you see these individuals. And this is just a figure from those slides showing that people with conditions like fibromyalgia, chronic fatigue, migraine have a lot of this problem. People with chronic low back pain, osteoarthritis, rheumatoid arthritis have sort of an intermediate amount of central nervous system driven pain. And then some pain conditions are really more peripheral, but you have to very carefully examine and phenotype the person to figure out what the underlying pain mechanisms are and figure out what's going to work and not going to work to treat. So I was supposed to talk about neuroscience. I will talk about neuroscience. We do a lot of functional neuroimaging. This is the first functional MRI study done in fibromyalgia. And in doing this study, in functional imaging, you look at the function of the central nervous system, not the structure. And using functional neuroimaging and giving people different types of stimuli, like different amounts of pressure, different amount of painful stimuli, you can learn a great deal about functionally what's wrong in these nociplastic pain states. And these original findings that we were the first group to find, that in fibromyalgia, the fundamental problem is an amplifier problem that I was alluding to earlier, that these people just are inherently much more sensitive to any kind of pain, whether it's applying pressure, applying heat, applying cold. They will feel a lot more pain for that same amount of stimulus intensity. And we could see by putting people in a functional MRI scanner that when we were giving the fibromyalgia patients a low intensity stimulus, they still felt that stimulus as being quite painful here. And then we could see in their brains that the fibromyalgia patients that were getting the low intensity stimulus, their brains looked almost identical to the healthy controls getting the high intensity stimulus. So when we matched for the amount of pain by giving the healthy controls twice as much a stimulus to get them to have as much pain, then their brains looked almost identical. But we could see that in fibromyalgia patients, that areas like the primary and secondary somatosensory cortex, the primary somatosensory cortex tells us where pain is. The secondary somatosensory cortex is one of the areas that tells us how intense pain is. We could see that those areas were being activated in fibromyalgia patients, even with that low intensity stimulus that wasn't capable of activating those areas in healthy controls. Now, we use a lot of other techniques in functional neuroimaging. We look at the degree to which different brain regions are either too connected to each other or not connected enough. And there's been an explosion of knowledge about the different neural networks that the brain uses to subserve all the different functions that the brain does. These are some of the networks, like the executive attention network, the default mode network, and many of these networks become impacted by chronic pain. And chronic pain, this kind of chronic pain is in large part a abnormality, if you will, of the connectome, or of the degree to which different brain regions are talking to each other and connected to each other. But even the size and the shape of the brain changes in people with this kind of pain. You heard from Dr. White the term neuroplasticity, and 20, 30 years ago, we thought whatever brain you had when you were a young adult, you had the rest of your life. But we know now the brain is constantly changing in response to any type of external stimuli. And when people have chronic pain, it seems like the brain is doing exactly what you would want it to do. It actually shrinks some of these regions of the brain, like the primary and secondary somatosensory cortex. I'm sorry, the secondary somatosensory cortex, the insula, some of the pain processing areas that are involved in telling what the sensory intensity of pain is. The only brain region that gets bigger in this kind of pain is the primary somatosensory cortex. And this would make sense because people have a lot of pain in different regions of the body, and the brain is trying to localize all that pain. And so it grows the size of the primary somatosensory cortex, whereas it shrinks the size of the secondary somatosensory cortex, which is involved in sensory intensity. But in case you haven't kept up with the literature, or you don't know much about the condition, recent neuroimaging studies done, different group has suggested that if you'd use functional neuroimaging and you do functional MRI, and then you take the functional MRI images of patients and controls and mix them up, is that you can tell with over 90% sensitivity and 90% specificity the fibromyalgia patients from the controls by looking at the functional MRI. So you cannot look at a structural MRI of someone with fibromyalgia and see anything wrong. And you certainly cannot look at an MRI of the areas of the body that they're experiencing pain and see anything wrong there. But a functional MRI of the brain will be quite abnormal, as study after study has shown us. And this is just another data slide showing how good the separation between patients and controls is when you use something like functional neuroimaging. Again, I just want to emphasize that this kind of pain can be superimposed upon conditions like rheumatoid arthritis. And this is just a number of studies of Yvonne Lee, an investigator at Northwestern, showing that this subset of people with rheumatoid arthritis that also have this kind of pain look a lot like fibromyalgia patients, that after their inflammation is well controlled with the drugs we can use to control inflammation in rheumatoid arthritis, you still have to use some of the drugs we use in conditions like fibromyalgia, the serotonin, norepinephrine reuptake inhibitors, to try to, if you will, turn down the volume control and improve the pain. And these next two studies are just functional imaging studies done by our group in rheumatoid arthritis. This is a functional imaging study to show that the degree of fibromyalgia, the higher the degree of fibromyalgia that rheumatoid arthritis patients had, the more their brains look like fibromyalgia patients on functional neuroimaging. But in a study published that same year in Nature Communications, we showed that the rheumatoid arthritis patients who didn't have any concurrent central sensitization or fibromyalgia, but did have a lot of active inflammation, that their functional conductivity patterns were entirely different. So that the inflammation that was being, the pain that was being driven by active inflammation looked a lot different on functional neuroimaging and functional conductivity than the pain that was being driven by the, if you will, the fibromyalgia or nociplastic pain. Why is this all important? This is the main reason that looking at pain mechanisms is important, is because the drugs that work really well for acute pain and for nociceptive pain, non-steroidal anti-inflammatory drugs, acetaminophen, corticosteroids if there's inflammation. And again, I don't like opioids at all for any type of chronic pain, but if they are to be used for chronic pain, they should be really reserved for cancer pain or sickle cell disease or conditions like that. But again, the point of emphasis here is that none of these drugs that work well for some types of pain work at all for this pain that is coming from the central nervous system. You have to use an entirely different set of drug and non-drug therapies. And notice here that one of the drugs we use to treat this kind of pain is an opioid antagonist, a drug, naltrexone, that actually blocks the activity of the endogenous opioid system. I'll show you in just a minute why that might be. But again, what we know is that these different brain regions and someone's sort of amplifier setting are set in part by a number of different neurotransmitters that seem to control how pain sensitive and how sensory sensitive people are. These neurotransmitters on the left, the higher they are, the more pain or sensory sensitive someone is. The ones on the right, the higher they are, the less pain sensitive they are. These are generally inhibitory neurotransmitters. These arrows here show you the direction of these neurotransmitters in the clinical condition fibromyalgia. You see that people with fibromyalgia have high levels, a lot of these excitatory neurotransmitters, low levels of a lot of these inhibitory neurotransmitters. And that's why they have the high amplifier or volume control setting. But the reason I like showing this slide is this also helps us explain or understand why none of these drugs work well in more than 30 or 40% of people that have, for example, fibromyalgia, because one individual might develop fibromyalgia because their glutamate is too high, in which case one of these drugs might help them, but another person might have fibromyalgia because their GABA is too low, and they'd need an entirely different set of drugs to treat, if you will, a decreased GABAergic activity problem. Opioids, talk briefly about opioids. It never was a good idea to use opioids for chronic pain. This is something that was largely driven by the pharmaceutical industry. There's been a lot said and a lot written, and all of it's true about the role that the pharma industry had in promoting chronic opioid therapy. One of the big problems with chronic opioid therapy is there never were trials done using the very high doses of opioids that ended up being advocated and recommended. And so we should have been able to anticipate all of the problems that occurred with opioids. We didn't. And now, you know, the initial part of the opioid epidemic, or the middle part of the opioid epidemic, was driven a lot by prescription drug overprescribing. The pendulum is swinging back now. There is not as much overprescribing of opioids as there was 5 or 10 years ago. But in certain settings, these are still overprescribed in perioperative settings and other settings. And these are just really dangerous drugs. We have to be careful with these drugs, not just because of their addictive potential, but most people are unaware that all-cause mortality, the risk that someone has of dying in the next year, is 50 to 75% higher in someone taking an opioid, a chronic pain patient taking an opioid. They don't just have a higher risk of dying of an overdose, they have a higher risk of dying of suicide, a higher risk of dying in a motor traffic accident. There's a number of different reasons that people die at a really increased rate if they are taking an opioid chronically. This is a study we did showing one of the problems that never was anticipated is that conditions like fibromyalgia, the body's own internal opioid system might be participating in the pathogenesis. You all know that we release endorphins and enkephalins, our body's own internal opioids. And what this PET study showed that we did a couple of years ago is that in fibromyalgia, it looked like fibromyalgia patients were producing too many of their body's own internal opioids. And it looked like a condition that is called opioid-induced hyperalgesia, which can occur when you give someone too many exogenous opioids, i.e. give them narcotic analgesics. But literally, it's a cautionary tale that there is a biological reason by which an opioid could actually make someone with fibromyalgia's pain worse, rather than just not make it better or just be unsafe to give them. We do a lot of work in cannabinoids now. I'll be happy to answer any questions about cannabinoids. We're just going to talk briefly about them, but we now have a lot of NIH funding trying to look at the optimal dosing, especially of cannabidiol or CBD in chronic pain, but also looking at THC. This slide is a joke. This is a cannabis plant talking to poppy plants, but it is true that in contrast to alcohol, benzodiazepines, and opioids, all three of those classes of drugs depress breathing. And when people take those drugs either singularly or in combination, they can be at high risk of opioid overdose. The 60 or 70,000 overdoses in the United States every year almost always have combinations of those three drugs. It turns out that there are no cannabinoid receptors in the brainstem, and so cannabinoids don't depress respiration. So there are safety and health problems associated with cannabinoids, don't get me wrong, but they are not associated with a risk of overdose. And Again, I think cannabidiol is an incredibly promising drug for pain. We're doing a lot of work with it. Now you probably know there's 2 different ways to get this. You can get it from hemp, where it's illegal. It's legal now in all states in the US. But if it comes from cannabis, it is legal in the states that either have medical cannabis laws or have actually entirely legalized cannabis. What we're learning though about THC is the same thing as opioids. A little bit of THC might be helpful for pain, but just like opioids, the higher the dose of opioid you use, the longer you use them, the more trouble you get into, not just with addiction, but also they just stop working. And we're seeing with THC that a little bit of THC is a lot better for pain than a lot of THC. And what happens when a lot of the states pass medical marijuana laws is they don't train physicians or patients how to use cannabis. And most patients are going to dispensaries, getting this really high THC cannabis and really over dosing themselves on THC, not taking the amount of THC that might actually relieve their pain rather than just leave them stoned. This is really more so for providers. If you do look at someone more from a mechanistic standpoint, you'll see there's some types of treatments that are going to work for different types of pain, depending on the type of pain. You'll pick different drug and non-drug therapies. But I'm going to end by talking about how important non-drug therapies are, because this is probably the other big change in the pain field, is how effective therapies that we used to be dismissive of in pain. And by the way, long haul syndrome, post-COVID, a lot of this is nociplastic pain or fibromyalgia. I was lead author of a review article. We wrote this 3 months after the COVID pandemic started, and we anticipated that there would be a long haul syndrome and described exactly what these individuals would be experiencing: problems with memory, fatigue, sleep problems, pain in different areas of their body, in addition to some of the unique problems associated with the acute COVID infection, such as the loss of taste or loss of smell. And again, probably the biggest thing that's happened in the pain field in the last couple of decades or so is the really dramatic increase in evidence that things like acupuncture, chiropractic manipulation, yoga, Tai Chi, hot baths, all types of exercise, cognitive behavioral therapy, all of these things now are really increasing dramatically with respect to the evidence base. And I just want to show the last slide here. Oh, this is a website that our group developed for self-management. It's surprising how much better you can make pain patients just by sending them to a website and having them work through getting more active, changing their diet, doing all sorts of different things. At some point in the future, we may be more aggressively using diet or nutritional interventions to treat pain. This is a study that we published a couple of years ago, and we're really aggressively looking at things like intermittent caloric restriction or some of the anti-inflammatory diets to treat pain. But this is the last slide. And just look now at what the VA and the DoD medical centers in the United States offer with respect to the non-drug therapies that are now reimbursed for chronic pain patients in these healthcare systems. Again, these are things that 20 or 30 years ago, I was taught to be dismissive of. A lot of these were sort of, if you will, Eastern therapies. But as more and more research has been done in these types of treatments, they now are really becoming sort of our mainstay of treating individuals with chronic pain, getting them involved in a number of these non-drug therapies, using the right drugs, staying away from opioids, and being very cautious with cannabinoids. So I'll stop there and take any questions that people might have.
Thank you, Dr. Claude. Pain is something that we are, all thinking about personally and professionally. So that was fascinating to walk through that. As folks are thinking of a question, I welcome you to go ahead and put it in the chat. I did put the link to the Pain Guide website there for folks to reference later. But one question that I was thinking about was that pain is often a reason people go to court. So think of a tort case where injury and pain are the result of the other party. And so how would fMRIs help or counter claims of pain by, so if X is suing Y, can those results, be used to kind of, prove that folks are having pain?
There's not unanimity about how or where functional imaging could or should be used forensically in this regard. I think those of us that do it do feel as though we can tell if someone's pain level changes fairly accurately using functional imaging. But what we can't tell right now, and this is actually probably intuitive, is like what score is that person going to give us on a 0 to 10 scale? Because different people use that scale differently. So I can't peer into a functional MRI and say, this person's pain is a 3 and this person's pain is a 6. But I can on a functional MRI say, this person is experiencing pain, because we see areas like the primary and secondary somatosensory cortices lit up. And I also could tell over time how much that person's pain changed from one scan to another. That we can do fairly accurately. But what would be inaccurate at present is to take a bunch of people like in the community and ask them what their pain score is from 0 to 10 and give me 100 functional MRI scans. That wouldn't be very accurate, because people would be starting off really over a continuum with respect to how do they use those scales. I would say though that we probably have done patients a really big disservice by talking about the people that fake, or at least clinically, if you're not working in an where there's comp and workers comp or things like that. If you're just working in a regular clinic where people come in wanting to get care for their pain, it's so unusual for people to be malingering and faking, because it's a miserable life to have chronic pain. And it's even more miserable to have chronic pain and be on opioids, because a lot of these people now have become dependent on their opioids iatrogenically, and they can't get off their opioids and we can't get them off their opioids. So now they have chronic pain and they're looked at by the pharmacist or the emergency room doctor as an addict, not just a chronic pain patient. So there's a lot of stigmatization of chronic pain patients. And for that reason, even though I like functional neuroimaging, we do a lot of it, I worry about it, like that we should use it to say whether we believe that someone's pain is real or not.
Right. That's fascinating. We have a few questions come in. Judge Barry asked, is there a difference between pain treatment for the elderly versus a young person?
The main problem in the elderly is that we just worry about all the treatment's safety profiles. For example, non-steroidal anti-inflammatory drugs, most of you know what those are. They're over the counter. Those are reasonably safe in younger people. People can have gastrointestinal bleeding, but they're not very safe in most elderly people, because they can cause major GI bleeds and death, or cardiovascular disease in people that have pre-existing coronary artery disease. So that's an entire class of drugs that we used to be almost our mainstays, that we're now really concerned about using non-steroidal anti-inflammatory drugs. We are super concerned about opioids. And again, in the elderly, you worry about additional things like risk of falls when you give an elderly person a drug that might in some way, cause them to cause balance problems, not just opioids, any number of drugs that might have those as side effects. So our therapeutic options are even more limited in the elderly. That's the main difference.
Right. Judge Greenwood is asking, is there any evidence that fibromyalgia can be caused by external mechanisms?
So if the question is, can it be caused by trauma? If it can be caused by, absolutely. I mean, there was an epidemic of fibromyalgia after every war. I was very involved in what was called the Gulf War syndrome after the first Gulf War. We later concluded it was really sort of fibromyalgia, chronic fatigue, what we now call nosoplastic pain, but it was triggered by the stress of being deployed to war. And military historians then went back and showed that every war the US has been involved in, starting with the Civil War, there's been a group of veterans that come back with unexplained pain, fatigue, sleep, memory problems. They look exactly like fibromyalgia patients. So it can be triggered by infections like COVID. It can be triggered by stressors like being deployed to war, or psychological stress and trauma. So yeah, it often can be. But that's incredibly difficult to adjudicate. If you, in a courtroom, to say in a given individual, was this person's fibromyalgia triggered by that motor vehicle accident? Because it's like, well, what was the, where was the straw that broke the camel's back? What was the thing that did it? Because clearly, in most of the individuals, for example, that where I've provided care and I've testified that I thought someone's fibromyalgia was triggered by a motor vehicle accident, a couple decades ago, I would say, I saw this person before, they didn't have any of this. I saw them after they had it. But in a lot of the cases involved in litigation, it's not nearly that clean, and it's not clear what someone had before, what came after. And as soon as people get involved in litigation, then I do agree with people like Norton Hadler and others that have written that the process of having people prove that they're sick makes them sicker. And so in our litigation systems and our disability systems are really just not good for patients, because it causes more stress, and it just is a really bad dynamic. So sorry I didn't answer the question definitively, but there really isn't a definitive answer. Fibromyalgia is real, but it's super hard to tell if it was triggered by an external factor or not.
Great. We have a couple more questions. I'm going to take them out of order here for a second, because this one, we all want to know the answer to this. What age is considered elderly? So.
Well, I'm 62 now, so it's something above that. So, yeah, it just keeps moving. So I'll say 65. Medically, that's what we typically have used. So.
All right, we're going to go to breakout rooms in a second, but I'm just going to take these two questions. So there was a slide that included, migraines and then related medications. And actually, Judge Bramlage had asked about explaining the slide again. I'll go to her second question do the normal medications work for migraines? And the Judge Bramlage, if you want to, put your, specific question in the chat, but do the normal medications work for migraines?
No. In fact, migraineurs are strongly recommended to avoid things like nonsteroidals and opioids because of what's called, those can actually trigger migraines to get worse. So no, classic medications don't work for migraines. But I would also say that migraine headache should almost be thought of its own unique kind of pain. A lot of migraineurs will have strong elements of what I've been talking about, but those are typically people that have sort of a mixed migraine tension headache. Pure migraineurs, that's a different kind of pain than I've been talking about, and almost a lecture in and of itself. What the headache condition that's more aligned with what I'm been talking about would be tension headache, or what's called chronic daily headache, where people have headaches almost every day.
Okay. All right. Two more. Do physical pain and emotional pain show up any differently in the brain? And if so, how?
They do. And Tor Wager has done some nice studies that were published in the New England Journal showing that there are differences in the brain, the representation of emotional pain and sensory pain. Again, a lot of it would be in the sort of both in functional MRI as well as in functional connectivity. But you can very much tell the difference. And I'm sorry, what was the second question?
Do they show up differently, and if so, how?
Again, there'd just be a different, what he showed in those studies in the New England Journal is he contrasted someone experimentally given emotional pain, that the different brain, surprisingly, the emotional pain, some of the brain regions more involved in emotion, that Dr. White talked about, the amygdala, the hippocampus, those are more activated in emotional pain than they are in physical pain.
Okay, great. And the last one before we go to breakout groups. So how much you treat small fiber sensory polyneuropathy?
So I just want to make clear that there's a big disagreement in the pain field about what that means. I don't think it means hardly anything. There are people that think we should be doing biopsies of the skin of chronic pain patients, and if we find this finding called small fiber neuropathy, that's a disease in and of itself that should be treated. I have written editorials about that and say I think that small fiber neuropathy is just simply neuroplasticity of the peripheral nervous system, because it's been found in virtually every chronic pain condition that's ever been looked for in, and it's found in Alzheimer's and ALS and a lot of other neurodegenerative diseases as well. So we think it's a non-specific finding, and people shouldn't really be using it as like to guide treatment. But we know that about 50 or 60% of people with fibromyalgia have small fiber neuropathy. So some well-meaning physicians are saying to their patients, how about if I do this test? I know it's going to be positive, and at least then you can say you have small fiber neuropathy and you can get your disability, because at least there's a biopsy finding that makes it real. So the patients actually often prefer a label like small fiber neuropathy because it's a little bit less stigmatizing. It's like, well, at least they found something.
Mm-hmm. Okay. Well, on that note, Jordan is going to send us to breakout rooms. We're going to have just over 5 minutes to kind of talk about this topic. Share, experiences you might have had, related to neuropathy or neuroscience of pain. And we'll see you back at 2 o'clock. And you should get a pop-up message that AAAS tech support is inviting you to join a particular room. You can just hit join. And if you don't see it, you can turn your camera on and ask us. We'll help you get there.
Affect memory. So for example, are there changes that can help one understand Alzheimer's and memory and the impact of one another, of one on the other? What about false memories and memory illusions? What do they tell us about the neural basis of memory and so forth? So his presentation, I'm sure, will be very, very interesting, especially since, as we all know, as lawyers and judges, that the issue of having people have their recollection refreshed, as they used to put it, at least in courts, is a real issue, a real challenge sometimes. So, sir, Dr. Stark, please go ahead. Thank you.
Merci, Alain. So my goal today is to try to tell you a little bit about, well, what neuroscience and other forms of things like cognitive neuroscience have really learned about how memory works, and to really try to give you the big sort of perspective on this, not necessarily what just came out in AAAS's Science last week or something like this, but the kinds of things that should easily pass any sort of like Dorbert kind of criterion here. So first off, as you might be able to tell by the amount of white in my beard here, I've been doing neuroscience of memory for a while now. And I can say really unequivocally here that nothing in the decades and decades worth of research in the neuroscience of memory says that we should be able to accurately retrieve large amounts of detail from long past events. This notion that you can go back, time travel, and be able to accurately relive with a whole bunch of detail exactly that which happened to you back then, that's not what we've learned. In fact, I haven't seen anything that's actually been able to give us a mechanism for that in all of our studies of memory. Well, we do have lots of evidence, though. We do have a lot of neuroscience evidence saying that fundamentally this isn't how our memory works. Our memory is structured in a very, very different way. And so if you have a system like a legal system that's designed around being able to do this and assuming that it happens, that this could be a problem. We could be working at odds here. Okay, so just the big picture view, what happens right now? You're listening to my voice, you've heard all sorts of other talks and everything this morning, you're going throughout your day. What happens in your brain to get it so that you'll be able to remember any of this later on? Well, we have a structure that you heard mentioned in the first talk called the hippocampus. And that's going to be critically important here. And you're also heard some of the things about, so for example, in the occipital lobe, a lot of the sensory kinds of things, visual things. Well, we perceive the world through these sensory systems. Visual systems in the occipital lobe, you're processing my voice and and the language in it and everything in your temporal lobes there. And Leonard gave a really, really fantastic thing on this. And one of the things that's come up is we've talked a lot about this notion of plasticity. Your sensory system, you don't see the world, you don't hear the world the same way that you did when you were a young adult. In fact, you don't really see and hear the world the way you did yesterday. These sensory systems are continuously tuning themselves up based upon the experiences that you have. And so if you are set up in such a way that you're having a very restricted set of experiences, this can be leading to things that we sometimes label as implicit bias. You are seeing the world differently, perceiving it differently. We also have this structure buried inside the hippocampus, and remember, it's called seahorse. It's the Latin seahorse hippocampus. My lab logo. Yeah, I study the hippocampus a whole bunch here. And what it does is it lets you rapidly store a bit of information from any given episode. Not the whole thing, not some great fantastic snapshot. It grabs a few bits and pieces actually from that one individual event. Now, as you experience the world, well, you're never really experiencing things that are totally new here. There's a lot of similarity between events here, and the neocortex outside in these various cortical structures here, there's learning going on there. And one of the things that it's doing is it's really letting you pull together multiple different events and tie them together into some sort of structure. But it's not that you're remembering each event perfectly. What really sort of happens is something happens, it leaves some kind of mark on you in your brain, some sort of memory, and that fades. Then another thing happens, it's kind of overlapping with it, and it fades. And another, and another, and another, and another, and another. And just visually, my goal here is to try to show you that sort of what remains, what's left over is the core, what's in common to all of them. And the rest of the bits that were just in one of them or so, all kind of disappear and fade away. We call this semanticization. Try saying that 10 times fast. But what it really means is that you're left with a gist and the details will go away. Okay, now sometimes we call this knowledge and wisdom and all this kind of thing, and that's great, but it means those individual details have gone away. And this is fundamentally what's going on inside your brain here. So even the original thing that came into your memory systems is distorted because your perceptual system distorted it. Over time, we have more and more chances to distort and change the memory, and we glom multiple things together. And actually, honestly, typically, this is a good thing. It's not so good a thing when you're trying to remember, like, well, was his jacket did it have 3 stripes on it or 4 or something like this? But that's not what our memory system was designed to do. All right, so let me try to actually demonstrate to you that I'm not just making all of this kind of thing up here. I'm going to show you a little video, nice little video. All I want you to do right now is just watch this video.
Clearly, somebody in this room murdered Lord Smythe, who, at precisely 3:34 this afternoon, was brutally bludgeoned to death with a blunt instrument. I want each of you to tell me your whereabouts at precisely the time that this dastardly deed took place.
I was polishing the brass in the master bedroom.
I was buttering his lordship's scones below stairs, sir.
Why, I was planting my petunias in the potting shed.
Constable, arrest Lady Smythe.
But how did you know?
Madam, as any horticulturist will tell you, one does not plant petunias until May is out. Take her away.
That's right, madam.
It's just a matter of observation. The real question is, how observant were you?
All right, we're now going to pan back. We're going to watch that scene again.
Action. Clearly, somebody in this room murdered Lord Smythe, who,
all right,
at
there go the
precisely
flowers,
3:34 this afternoon,
new flowers,
was brutally bludgeoned to death with a
it gets
blunt
so much worse than
instrument.
that. There goes the
I
body.
want each of you to tell me your whereabouts at precisely the time that this dastardly deed
for a
took
suit of
place.
armor. Oh, look what the
I
detective
was
is wearing.
polishing
That's
the brass
changing.
in
New
the master
flowers,
bedroom.
new backings, new
I was
paintings.
buttering his
Here's the new
lordship's
body.
scones
Here's the
below
new murder
stairs,
weapon.
sir.
Why, I was planting my petunias in the potting shed.
Constable, arrest Lady Smythe.
All right, so this is actually an ad in the UK saying, watch out for cyclists. And as a cyclist myself, that's a very, very good message. To me, however, it says something different. It at least is a really good demonstration of something. Now, some of you may have noticed a detail or so that had changed. And, you know, you felt pretty good about yourself. Say, hey, this is what this Dr. Stark is doing here. Wait a minute, that bear is all of a sudden, that's not the same thing there. Yeah, nobody noticed all 21. I know, because I don't even notice all 21, and I've shown this video about 50 times or so now. It tells us, though, that that basic idea about memory is right. You have a limited capacity. You got a few details and your memory held only the gist. So the camera pans along the first time, and if it really were like a video recorder, you would have been saying to yourself, oh, wait a minute, yeah, there's a bear, there she is, she's holding this bedpan warming kind of thing or whatever. Pans along here, and then the second time it pans along, when that bear has turned into a suit of armor, you would have said, whoa, 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 wait a minute, that's not the same thing. That changed. You would have gotten the paintings, you would have gotten what he was wearing, you would have gotten the body, you would have gotten the murder weapon, you would have gotten all of this, but instead, that was never, ever, ever in your memory. Your memory consisted of something like, yeah, it's a murder mystery. And maybe it was the gardener who did it because she was planting her petunias in the potting shed. Okay, you got a few details and you held a gist. And that gist, by the way, came from a whole bunch of things because you know about clue murder mysteries like this. You have those experiences. So your memory is shaped by those experiences. All right, so I can be done. That's how it works. Well, you know, let me try to actually formalize this a little bit. And let me also try to convince you that this isn't like some big brand new revelation to people like me. So this is a quote from Frederick Bartlett. And what Bartlett said is he wrote out, memory is not the re-excitation of innumerable fixed, lifeless ideas and fragmentary traces. Now, okay, we don't really talk like this all that much anymore, at least write like this. So what are we saying? Let's unpack it here for a second. It's not re-exciting, reactivating, pulling back here, innumerable, this huge number of fixed and lifeless ideas. Things that, it's not that something's been etched into your brain and it stays like that and doesn't have a life, doesn't change on its own. No. What it is, it's an imaginative reconstruction or construction. So you're making it up. Out of what? The relation of our attitudes toward a whole active mass of organized past reactions or experiences. So everything that's happened to you before, laid on little bits and pieces and all this kind of thing, how you think the world should be, memory retrieval is how you think the world should be. That's what he's leading with. And to a little outstanding detail, which commonly appears in image or language form. So you get a few bits from that. Remember I said the hippocampus stores just a little few bits of the information and the rest is, all right. So every memory retrieval you're having gets a few bits from that original thing maybe, and the rest is just kind of filled in based on how you think it should have been. And I want to draw your attention to the date, 1932. That's been a while. This kind of thing should be able to pass to heart. So, not very real life what I've shown you though. Let me try to actually turn this into something other than a little video clip. So let me start off with some of the pioneering work of my colleague at UC Irvine, Elizabeth Loftus. And in some of her early pioneering work here, she would show people videos of something like a traffic accident. And then afterwards, divide people into two groups and ask them one of two questions. How fast was the black car going when it hit the blue car? Or how fast was the black car going when it smashed into the blue car? They witnessed the same thing. They should have the same memory. They should come up with the same speed, right? Wrong. Depending upon how you ask the question, you get two different answers, 34 miles an hour with hit, 41 miles an hour with smash. So how you ask the question matters. Another version of this same kind of thing. You see a car driving along a country road in a little video clip of hers. After you watch this clip, it's a couple-minute clip. After you watch it, she would ask people one of two questions. Either how fast was the white car going while on the country road? Pretty generic sort of thing here. Or how fast was the white car going when it passed the barn while on the country road? And of course, the trick is there was no barn. Bring people back a week later and just say, hey, tell me, what did you see in that video there? Tell me all the stuff that you saw. Well, if nobody ever mentions a barn, still 3% of the people actually report having seen a barn. Okay, look, country road, what else is going to be on a country road? Again, they did not see it, but they remember having seen it. But almost 6 times as many people, if you have a little bit of a leading question, it's not even about like, what color was the barn? Or did you see the white barn or anything like that? No, you just make a little passing reference to it. Almost 6 times as many people, 17%, report now seeing a barn. Oh, so we can distort the contents of the memory with information presented afterwards. It can become a part of the memory. Okay. Here's another little one. This one goes back to 1974, Sullen and Dooling. They had people read this paragraph about Carol Harris. Carol Harris was a problem child at birth. She was wild, stubborn, and violent. By the time Carol turned 8, she was unmanageable. Her parents were very concerned about her mental health. There was no good institution in her problem in her state. Her parents finally decided to take some action. They hired a private teacher for Carol. Okay, little paragraph kind of thing. We can test your memory for this sort of thing. We could do something like a week later, we could bring people back and say like, did we tell you that she was wild, stubborn, and violent? You should say, well, yes. Yes, you did. Did we tell you that she was deaf, mute, and blind? No, that wasn't in there. You should say no. Okay, so here's the trick though. Half of the people read about this person, Carol Harris. Half of the people read about Helen Keller. Same exact paragraph, you just changed the name. Now, when we take a look though at this deaf, mute, and blind, well, only 5% of the people said, yes, you told me Carol Harris was deaf, mute, and blind. Pause here for a second. 1 in 20 people that are in the jury pool and all this kind of thing, believed that we said, Sullen and Dooling said she was deaf, mute, and blind, and there was absolutely no reason why you should have thought that she was deaf, mute, and blind or anything like that. Still, 1 in 20, and they're out there. I don't know what's wrong with them, but the bigger point I'm trying to make here, half of the people said, well, yeah, you told me that. That was in the paragraph. You said that she was deaf, mute, and blind. No, we didn't. In fact, not in there at all. And yet, well, you should have. I mean, come on, it's a paragraph about Helen Keller. Why didn't you say that? We all know that about Helen Keller. It should have been in there. Should. Huh. Okay, you see somebody come flying out of a liquor store, gun in one hand, wad of cash in the other. Runs down the street the other direction, ducks down an alleyway. Hey, what'd you see? Young guy comes flying out of a liquor store. How do you know it's a young guy? Well, little old ladies don't rob liquor. Did you see it? Or do you just have the belief then that it's young guys who might do that? Oh, Helen Keller. Of course you should have said that. Of course it's a young guy. All right. So far, what I'm showing you though is undergraduates or whatever taking psychology experiments, and that's not really real life. Besides, it's not exactly emotional and traumatic. In most of these kinds of things, I mean, certainly in eyewitness testimony, it's often an emotional, traumatic kind of thing, or look, you're in court for a reason. And so it's a big kind of deal. And so, of course you'd say, like, I remember it like it was yesterday. It was this big kind of thing. He told me the contract would be null and yada, whatever the case is. All right, well, let's try to amp this up a little bit. To do this, I'm also going to actually take a step out of work in humans, and I'm going to turn to work in animal models for just a second here, because one of the other great things is they got the same basic memory system that we do, and we can control their world a whole heck of a lot more. So, all right, take a rat, stick a rat in a box, this blue box here. This is the work of Brian Wilchin and Alcino Silva, and give them a shock in that box. Now, it's not like some excruciating, painful kind of thing, but it is sort of annoying and this kind of thing. I don't really like it. We can test their memory, not just by saying, yo, rat, do you like this box? Well, no, you can test it more formally by doing things like you take that rat and you can put them back in that same box. And if the rat remembers that it got shocked in there, it'll exhibit something called freezing. It's a classic prey behavior. They just go and they don't move. Be still so your predator won't see you. The fear response. All right. And so you could put them in that same exact box and see how much freezing there is, or you could put them in a similar, but not exactly the same box. You change the floor around, what's on the wall, so it knows it's a different place. And we could even see how detailed, how specific is this memory. Well, after a day after the original shock, they did this and they found that there was a really big difference between the context they were shocked in and the context they weren't. So at this point, the rat has the memory that the blue box is bad. All right. Well, if instead of testing them the next day, you test them 2 weeks, 4 weeks, 5 weeks or so later, and you then say, hey, what do we see? Well, what happens here? The blue box, actually, they stay freezing in that pretty darn well. They're holding on to the memory because it was a traumatic kind of thing that they had gotten shocked in here. But here's the really interesting thing. Over time, the contents of the memory change from blue boxes are bad to boxes are bad. Stick them in any box and the rat freezes. And it's not that they're doing something, the researchers are asking them leading questions or anything like this. No, it's a rat. It's living in its cage and all that kind of thing. And the contents of the memory naturally changes over time and becomes more generalized and less detailed without any manipulation or anything like that. Here's another fun one. So this is another kind of a thing that shows that actually the contents of the memory, we have mechanisms in here to alter and update the contents of the memory. So the way this works is, again, you do something, in this case, they were playing a tone and having a shock here. You do this, you have the animal learn this. And then after a day, you just go and play the tone. It's like a reminder, beep. Oh man, that shock's going to be coming. I'm getting a little nervous. That shock's going to be coming. You don't shock them then. Instead, what you can do is right then and there, you inject a little something into the hippocampus here in their brain. And what you're injecting is the same kind of thing that would have prevented initial learning of this in the first place. It's stuff that makes protein synthesis, all sorts of great stuff happen that gets it so that you can really learn new information. You're not learning something new. What are we doing here? Well, here's the phenomenon. If you test them, then the next day, what you see is that if you inject this thing of vehicles like saline, it doesn't do anything. Well, nothing really happens. They hold on to that memory. If you instead inject this thing that is blocking the formation of new memories, you actually can go and eliminate the memory. Retrieving a memory puts it into a state that is plastic, labile, malleable. The idea being that we're having an event. We've seen something. Oh yeah, that's the guy I met yesterday. Oh geez, what the heck was his name? I've forgotten. Oh, it's Bob. Oh, okay. And that's right. I've now learned something new also about Bob in this interaction. So I'm going to update my memory of this face here, this person, this Bob. All right. So when we retrieve the memory, we put it into a state which makes it changeable so that we can update its contents. So when something happens to you and later on you're questioned about it or you're thinking about it yourself, you're putting it into a state that makes it able to be easily changed and modified. So if somebody asks a leading question, that could get into your memory as if it's just the neuroscience of memory gives us mechanisms for this kind of thing really easily. It's kind of like that fishing trope here. So if you go, and this is the story that you tell over and over and over again, each time you're reliving this kind of thing, the original memory, yeah, that's not what's in your memory anymore. Maybe you know that you're still lying, but so that your final one is somewhere in between these two, but the contents of your memory have been updated. They're not that anymore. You have lied so much you believe yourself. Okay, so let's take this into humans. It's not just rats that show this kind of thing. So this was some work done by Morgan in the early and mid 2000s. He took soldiers going to a military survival school. And what they're trying to do is learn what to do when they get captured, if they get captured, sorry. And so what they have is they have some classroom kind of material here. They learn the techniques and all this, and then they have a practicum in which the soldiers go out. They're out overnight, they get captured, and then they get brought in for 30 minutes of interrogation. And they got somebody right here trying to get facts from them. That's kind of the exam. Do you do what you were supposed to have done? All right, so then Morgan turned this into an experiment by 2 days later testing these folks with a photo array. So just put on a table, a bunch of photos, and the interrogator's face could be inside that set, or it might not. So only question right now was, yes or no, is the interrogator's face in this photo lineup here? Well, if the interrogator's face was present, 3/4 of the time, they say yeah, and they go on and they pick somebody. 1 out of 4, these elite soldiers, 1 out of 4 say, no, he's not in there. That's the problem with memory. But it gets even worse when the interrogator's face isn't there. Not there 2/3 of the time. So the yes is 75%, no is like 66%. They say, yeah, it is there. And they go on and they pick somebody. That was not the interrogator that was 30 minutes right there in front of their face getting information out of them just 2 days ago. By the way, you amp up the level of stress in this kind of situation, it actually leads to fewer true positives. This goes down and this goes up. That's not good. It gets worse. They also did some things in like the interview afterwards, a debriefing kind of session. They tried that misinformation kind of deal. What happens if we ask some leading questions here? So they could ask questions in a non-leading way, like, please describe the uniform and rank of your interrogator. If you do not remember, please indicate that you do not remember. All right. Or they could ask it in a leading way. Was the uniform worn by your interrogator green with red boards or blue with orange boards? All right. Now then you go on and you ask people, hey, what kind of details do they actually have in the memory? What do they believe was there? What this shows, so in the green is when there was no misinformation, and the red is when there is misinformation. So they could implant the guy having glasses, there was a telephone in the room, what his uniform was made out of, whether there was a weapon present. They could implant all that information just by this leading question. But wait, there's more. This was the interrogator. If during these kinds of leading questions and this sort of thing here, they slid across the table this guy's picture, didn't reference it, didn't say your interrogator, see this guy, nothing like that. They just had it there for the person to be looking at during this questioning. Guess what? Whole bunch of the time, false memory as to who was the actual interrogator. They would increase the false rate even further, and they would pick this guy. I don't know about you, they don't look all that similar to me. Again, 30 minutes, just a few days ago. Okay, so these are big problems. Big problems for the legal system here. To me, though, they're not actually the biggest problem. The real problem is all of this goes against how well people think memory works, how judges do, how jurors do, how the general public thinks memory works. If you ask people, hey, human memory works like a video camera, accurately recording the events we see and hear so that we can review and inspect them later. Do you agree or disagree with this statement? What you find is that the general public, about 2/3 of the time, goes along with this and says, yeah, that's how it works. And the difference in these cool colors is just whether you strongly agree or whether you mostly agree with it. You ask memory experts, people like me. I'll remind you, by the way, academics, we're paid to disagree with each other just like lawyers are paid to disagree with each other. That's kind of what we do for a living. You can find very few things that we agree on all that much. And yet here, the only thing we disagree on is how vehemently we disagree with a statement. And still the overwhelming majority of us are like, yeah, no way, we strongly disagree with that. This kind of thing has really, really big implications as well. Remember, I said that you're seeing the world, it's tuning up this perceptual system, and this is one of the things that leads to implicit bias. Now, most folks by now have gotten a decent amount of implicit bias training. I wanted to highlight one study because implicit bias comes about from our memory system being adaptive here. I wanted to give you one kind of like notion as to just how big this can actually be in terms of impact. This study was called Looking Deathworthy. And what they did is they had people, they grabbed a whole bunch of mug shots from cases in the Philadelphia area, about 600 or so of them. And these were all, they tried to constrain them so they'd be very similar kinds of things. There's a Black defendant, a white victim, it's all death eligible kinds of cases. They then took these faces, they took it to a whole nother group of people and they said, hey, we just want you to give a rating on these faces. How stereotypically Black do you think this person's face looks? Give me a rating. They knew nothing about the other study, not even that there were mugshots, nothing about any of this kind of thing, just give me ratings, bum, 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 bum. Researchers then took the ratings, split them into the more stereotypically African-American and less stereotypically African-American rated faces, and then went back and said, what were the odds that the person actually got the death sentence versus something like life in prison? What they found is that over twice as many of the more stereotypical ones got the death sentence versus the less stereotypical. How stereotypically Black you look affects the sentencing. This is pretty huge. This is a clear sort of example of implicit bias. By the way, I'm going to stick in the chat right now a link, implicit.harvard.edu. You can go and take a whole host of different implicit bias tests. You can know how they work. It'll still nicely show whatever biases you may have on that. In the comfort of your own room, do this at some point. It's incredibly enlightening. I've done it and it's incredibly enlightening. Okay, why do we have such a weird, bad performing memory system though? Well, because it's not performing badly. It's doing what it's expected to actually do. Our memory system isn't here so that we can look back in our old age and say, geez, I remember when, and do some mental time travel and relive these events perfectly, like some VR kind of thing. That's not what we have our memory system for. Our memory system is to let our past experiences guide our current and future actions. So to let the past be more adaptive in our decisions now, to guide us when we come to the crossroad, which way do we go? That's what it's there for. And you don't have to go and relive, well, this time this, and this time this, and this time this, and this time this. No, you want something that's going to automatically have shaped you to prefer one sort of path, one kind of action relative to another, because it's been good. This makes, though, errors and biases a kind of the evil twin of wisdom and abstraction. And fundamentally in our brain, this trade-off kind of has to happen. So, all right. Quick recap of where we are so far. We not only forget, but we generalize and believe things happen that are just similar to things that actually happen. We fill in a lot. Misleading information or misinformation presented after the fact can distort the contents of our memory. This happens automatically. Look, we already saw in those rats there, it happened automatically in them. It's not like the researchers are whispering in their ear, yeah, red boxes are bad too, as they're sleeping or something like this. No, just the mere act of us certainly retelling the information, filling little bits in. Something came from somewhere else, you heard it on the news, somebody else mentioned in your discussion, you came up with, oops, it's now gotten into your memory as well. This goes on routinely. It's typically, though, a good thing, but nobody is immune to this. Eyewitnesses, police, jurors, judges, spouses, memory researchers, none of us are immune to any of this kind of thing. And it's not abnormal. It's actually how an adaptive system works to try to abstract across all of these different events. But if you expect that somebody is actually going to be able to do that, be able to remember these details from that event itself, you're fooling yourself. That's not how it works. And yet a whole bunch of the legal system is based on that idea that you should be able to do this kind of thing, in particular if it was a big kind of deal. So what can we do? Well, look, we're not going to change how fundamentally the brain works. We have evolution that's given us this system here, and that's not changing. But we can actually minimize, baked into the system, the kinds of imperfections. We can have it try to minimize the imperfections, and we can try to change how much weight is actually placed on eyewitness testimony, on confidence on it, on that specific sort of detailed recollection. So I like putting this in here. So these next couple slides have a lot of bullet points in them, and I'm not going to really hit them all. I'm doing this for those who want to go back later on and be able to hit some of these things, like come up with the course case numbers and this kind of thing. There are a lot of things that the system can do, from the police all the way on through, to try to get the best information out of the witness. There's this thing called the cognitive interview, which is a really, really good idea. And there are a couple of states that are looking at trying to have something like this in their interrogation procedures and revised lineup procedures, et cetera, to try to minimize this sort of bias. I'm a big fan of people using notes. And usually when I mention this, I get a judge say, well, you can't use notes. And another judge says, oh, what do you mean you can't use notes? I've been using notes for 20 years. And then they argue amongst themselves. And I'm a big advocate of it. It actually helps you in the first place be able to actually get better information into your mind. And afterwards, it does help you actually then kind of reinstate that context and have a better retrieval. Big thing, is going to be with jury education, whether this comes from jury instructions, whether it comes from material that's, other material that's given, like, as the jurors are waiting and everything, some sort of instructional material. There are a lot of things that we can be doing to try to get it across to folks that just because somebody is really confident does not necessarily mean that they're accurate at all. There's a bad relationship history there. Even things that are personally traumatic. Don't you think I would know who did it? Don't you think I would know? No, I don't necessarily think that you would, because we had plenty of cases when that doesn't happen and it's distorted and wrong. And that eyewitness testimony is not like DNA. That's the guy who did it. That classic sort of thing is like, no, that is not how it works. I've had a judge tell me that 2 eyewitnesses contradicted DNA evidence and that the jury went along with the eyewitnesses in a case that she had presided over. All sorts of stuff like this. And this just, we can't rely on it like that. It's not just me saying this. There are things like the National Academy of Sciences had this report identifying the culprit, huge tome you can go on in there. One of the big things I want to draw out on this is, using jury instructions. Is it going to be perfect? No, I can show you data shows that it's not perfect, but shows that in fact, at least it does something here. This is going on. Those couple of court cases that I had a few slides ago, you can refer back to. One of the judges in another one of these talks several years ago, Judge Dankoff from Ohio, heard my talk and said, I can't I can't run the court the way I used to here, because given all of these kinds of problems, we have to adapt. It's my responsibility. I have to. And so he crafted some instructions, sent them for me. And you can see things here, that, for example, asking how fast was the black car going when it slammed into the white car versus, okay, we know, yeah, this is what he's pulling from. And the upshot, he had several cases that used this. There, of course, were appeals, as you might expect. The Ohio Supreme Court in the end came down to saying that his only real missteps were things like, for example, having a court-appointed expert and the jury instructions giving the same thing, because then it looked like the court was siding, with that one expert side and this kind of thing, some procedural kinds of things like that. Another one was that it was some of the stuff in there wasn't relevant to that particular case and this kind of deal, but it survived the Supreme Court kind of thing there. So, final conclusion here. Decades and decades and decades worth of neuroscience and experimental psychology have shown that Frederick Bartlett was right in 1932 here. The issues that we face stem from fundamentally the neural mechanisms of memory. So the neuroscience of memory has really shown the biological basis for it, and things like the Innocence Project have shown its impact, the real world impacts of this kind of thing. So for me, looking at this, it's time to change how we think about memory and how it's actually used in the law. And for that, thank you very much, and let's open up for some questions.
Thank you very much, Professor Stark. That's fantastic. Well, I think there are a number of questions that have popped up, but I'm going to seize, take advantage of my position, if I may, slightly, and ask a number of questions that you can deal with that have popped in my mind. So one, towards the very end, you did raise some, you did have a slide on ways of, I guess one way of putting it is minimizing the negative impacts, at least in a legal setting, of our naturally imperfect memories. I think that might be something that people would like to discuss more in a breakout group, and I'm sure it probably warrants a presentation on its own. I know you've worked on jury instructions in some instances with some courts and so forth. Are there any other things about it that you'd like to say? That's A. B, a slightly different question, maybe it just shows my misunderstanding generally, perhaps slightly tendentious too. But that is, so are there, leaving aside the problem of leading questions and so forth, and the plasticity of our brains, well, actually goes back to that as well. Is there evidence that certain brain structures or brain functions are going to help people have better memories or not? In addition to what we were discussing today of how time and so forth can influence the mutation of memories. And finally, one other question, which is maybe very Washington, because I'm from the DC area. Bosses and busy people here in Washington always want the bottom line up front. They want that gist, which you have indicated to us is what nature has taught us, to our brains, to learn how to boil things down to, right? The gist. But from a memory point of view, if people have studied this, does it make it more or less likely that somebody's going to remember the gist later on if all you say is, look, the bottom line is X, rather than having somebody go through the rigmarole of learning something, and then either on their own or eventually getting to that gist? That may be sort of a strange question, but
no, it's not a strange question at all, because it gets down to fundamentally, how do we learn best? And
yes. Thank you.
It is going to be better if you sort of come to that gist on your own, or are sort of guided to that gist, that TLDR, the executive summary, whatever you want to call it there. Because if you just get that the once, that's one shot for you to get this information. And what we've learned about memory is that, one shot is not the way. I mean, it's not like, okay, when you were in elementary school and trying to learn vocabulary words, did you just like write out the flashcards once? And well, look, you wrote them down there, so you know it. You don't even need to run through them. Okay, fine, maybe run through it once. Well, no, of course you took multiple times. It takes multiple times to actually learn this kind of thing and hold on to it. In addition, though, you're bringing your own baggage, but your own way of thinking and knowledge and expertise. So any way you can put this in a framework that fits with how you think and what you know about the world leads to better memory as well. If you have a good schema for it, it leads to a better memory of it. Now, one of the problems is you'll then fill in things based on that schema that may not have been there, but it is better for you to do this yourself. Just like, I mean, part like taking notes in some ways is you coming up with that just that executive summary, that's what you're writing down. And this does actually lead to far better learning. People in doing research and education also have shown this kind of thing time and time again. So it is better to have some amount of it. There's, we're learning a lot about what's the right kind of length. Should you sit down and listen to testimony for 6 hours? Yeah, I mean, when I first really started doing these talks, and I started thinking about what the poor jurors are going through, the kind of memory tasks that they have. So let me get this straight, right? You're going to sit there quietly, not taking notes. Okay, fine, some let them take notes, a lot don't. Not taking notes, not asking questions, not consulting anything outside. You're going to listen for several hours, 6 hours, whatever in a day worth of information, often people contradicting each other, a whole bunch of stuff of arcane stuff that you don't know anything about or whatever. And at the end, you're not allowed to talk or confer with anybody and have any kind of study group to try to actually, was this what? I don't know, does this? You can't do any of that kind of thing. And at the end, the final exam may determine whether somebody's going to go to jail for the rest of their life or something like this. It's absurd. The notion that I would run a course like this at a university, like this is how you're going to learn really well. No, it is though the notion that they're going to be getting a whole bunch of gist and each person gets their own sort of gist from it. You lock them in a room together and hopefully then those gists go and give that's kind of how our system can actually work as well as it does. I can't come up with a better system, by the way. So don't think that, us academics think that we have the big answer on this. So let me hit a couple of the other things and then I'll sort of thread back into that. How I presented to prosecutors or public defenders. I've done prosecutors, public defenders, police, state, federal judge associations. I've done probably about 80, 90 or so talks by now across a different range of groups. The prosecutors love the bit where I'm saying like hit versus smash. They're all like taking notes on that one and this kind of thing. And sorry, I kid, but only slightly on that. But I do think this is something that, again, if we know that this is what's going on and how it works, we can work with that in the system to get closer to the truth of what happened in any of these things, whether it's a criminal, kind of thing, whether it's the civil sort of thing. We're all trying to get down to the truth, and let's use whatever data and everything we actually have on it. And we got to know, okay, this data is going to be a little flawed, but the system already does this. Yeah, this guy, he says that such and such and such and such was the original agreement, but he stands to gain about $4.5 million if it comes out. Well, yeah, we as jurors, we're going to say, yeah, that guy might not be, whether he's lying or selectively attending to different aspects of this. Okay, we know to put less confidence in that. One of the ideas here is just overall damp the level of confidence down. Now, question here is taking notes is the greater danger that the jurors not paying attention to the evidence offered during that time? Great question. So I'm going to assume that this person, when they went in throughout elementary and high school and college and law school and everything, didn't take any notes during the class ever, because they might miss the little pearl of wisdom that was coming out of the lecturer's mouth at that point, and took all of their notes down, maybe later that day or a few days later from that lecture, right? That's the way you did it, huh? No, that's not the way you did it. I don't know anybody who's actually done it that way. Because what we're doing, we are very good at switching back and forth. You write a little bit and you realize that somebody's kind of droning on and on, like I'm sort of doing right now, and you're writing a little more. Oh, wait a minute, there was something. We even have this little thing, the echoic buffer, that lets you go back a couple seconds and sort of replay in your brain what happened to grab that. This doesn't seem to be a huge kind of problem, for things. And so we're pretty darn good at being able to stop. And again, if you have multiple people actually doing this, you have a dozen fail safes or whatever in there. What do I think about allowing all testimony trials to be video recorded and allowing jurors to review as much and as often as they wish during the deliberations? Thank you for asking this question. I know there are two answers to why this isn't happening. One is just money. And I do appreciate, from doing this for so many years now, I do appreciate how financially strapped and everything so many jurisdictions are. And I think that is a crime. You will have every single vote I can possibly give, which unfortunately is just one and probably not in your jurisdiction when it comes to funding more things for the courts for that. And then the other is then that notion of how is it going to throw, how is it going to bias, the system's been working, don't rock the boat and all that. But look, a decade ago, I had a little pen and special paper that I could be taking notes with, and I could go back and tap on that spot on the page and it would play back the sound. It was $100 pen, exactly what was going on at that time. And we can't do this. When I realized how difficult it was to even get a transcript of it, that it's not something that can be readily done, I was dumbfounded. And so we have the technology now. It is so easy. You have people's dash cams automatically recording what's going on all the time and this kind of thing. So yeah, the ability to go back and no, wait a minute. I think it was the prosecutor who said anything about the gun. The witness hadn't said that. Yeah, I don't know. I kind of thought it was all right, well, oh yeah, here he is. Here's his testimony. Boom, there it is. Wait a minute, it was the prosecutor. They can have this in the jury room if we're trying to get at the truth. Now, there's the idea, how much is it going to bog it down and all this kind of thing. Maybe you have some system in terms of the amount of number of times you can go and do this or whatever the case may be. But if we want to get at the truth, to me, this helps us. Look, if there were like video recording surveillance evidence of somebody committing the crime, you said, geez, I don't know, we didn't used to do that kind of thing. It actually took like, true eyewitnesses, and really only eyewitnesses who were landowners and voters. Those are the only ones we're allowed to listen to. And so of course we can't use this new fact. Well, no, of course we use it now because we realize it gets us closer to the truth. So why not? I know money, but if we could solve that problem, I think that'd be great.
We're about to move into breakout groups, and I won't keep you longer, but at some point I'd be fascinated to learn more about linking what you've discussed with some of the structural issues we discussed before and whether any of that affects memory and brain issues and all that. But let's go, Jordan, if you want to break people up into random breakout groups for the next about 7 to
All right, the rooms have just closed. We'll all be coming back into the main room here in just another moment. Great. Well, welcome back from your breakout room. I want to thank Dr. Craig Stark for his presentation. And I'd like to ask the same thing I did last time. If you can drop in the chat some of the things you talked about, any takeaways or aha moments you might have had. We all benefit from seeing those. We are going to stay in California for our last presentation. This topic is addiction and the opioid crisis, and we're going to be hearing from Daniel Ciccarone. He is joining us from University of California, San Francisco, where he is a professor in the Department of Family and Community Medicine. And Dr. Ciccarone has been the principal or co-investigator on numerous NIH-sponsored public health research projects. He's currently leading the heroin and transition study. And so they're looking at ethnographic information, economic and statistical modeling. And so it's going to look at the rise in heroin use and then the diversity of heroin source forms, and then synthetic opioids as well. He has published numerous articles in various journals and is the associate editor of the International Journal of Drug Policy. And we're very, very pleased to have him here. Dr. Ciccarone, you have the floor.
Thank you, Ms. Allen. Thank you for the kind introduction. Hi, everybody. Excited and honored to be here at this neuroscience seminar sponsored by AAAS. Let me see if I can share my screen. This is always the dicey moment. Does it work? I'm going to put it into slideshow. Can someone just confirm that that's all visual?
Yes.
Okay,
Yes,
great.
perfect.
So let's shift focus now. I want to talk about so I'm going to get into the world of public health and public policy. And the thing that I know the best as it relates to neuroscience is what's going on with the opioid crisis. And I'm going to talk about it from a macro perspective, that's again, public health, public policy. And then I'm going to get into the clinical perspective and then what is going on in terms of addiction. How do we understand our brain model of addiction? So I up front, I want to say some disclosures. I'm on the scientific advisory board for a private company called Solero Systems. We're working on a novel opioid overdose intervention system. I'm also an expert witness on the plaintiff side in the mass tort of federal opioid litigation. So you'll see here that I do have some biases. The biases are in the direction of public health and trying to understand the crisis of the opioid crisis as it is. We'll go through some national data. I will describe my metaphor of the triple wave of overdose deaths due to pills, then followed by heroin, followed by fentanyl. And then we'll get into this clinical stuff around trying to explain why it is this triple wave happened and how we can understand it both from an individual perspective and a public perspective. I'm sponsored by the NIH, specifically the National Institute of Drug Abuse, NIDA. This study has been going on for 7 years now, the heroin transition study. It's a multi-methodological study where we're looking at both the breadth of the problem using statistics and epidemiology, but we're also looking at the depth of the problem by using the cultural anthropological tool called participant observation ethnography, where we actually observe drug use and try to understand the reasons why people transition from pills to heroin to fentanyl. And you'll see little snapshots of this work all along the way. You're of course invited to read the numerous papers that we've written out of this study. So we could spend the entire time talking about this one graph. What you're looking at here is over 100 years of US mortality data. This is the death rate of Americans starting around 1900 to present. We see some big stuff here. We see, of course, the horrific, historic Spanish influenza pandemic from 100 years ago, the late 19-teens. We see how high that caused the death rate and what a steep increase it was. But then, as we would expect in a modern, advanced, technologically advanced healthcare system, a decline in in death rate over the next 100 years, right? All the advances in safe water, safe food, making cars better, declining pollution, et cetera, working on poverty issues, we see a decline in death rate until, I think my graphics got a little bit, oh, here we go. Until, of course, the current year, the current past year, 18 months now, we're in a new pandemic. Now, it's bad, but it's not as bad as the Spanish flu pandemic. Of course, we have better ways of treating influenza disease. And even though it caused a huge spike in mortality, it's not as bad as it could have been. Of course, we also have prophylaxis. We have a number of vaccines now that will reduce hospitalizations and mortality further. But that's not the job of today's talk. Today's talk is about what happened just before that. We also see here an unprecedented 3 to 4 year rise in mortality rate. What caused this? Drug overdose, an epidemic of crisis proportion where drug overdoses exceeded both in number and rate the number of deaths due to car accidents, gun violence, and even HIV at the height of the 1990s HIV epidemic. I describe, and what's driving drug overdose is the class of drugs called opioids. And I describe this as a triple wave metaphor. This metaphor is taking on public policy life. It's mentioned all across many jurisdictions, including the Centers for Disease Control use my metaphor now, where the waves of 3 subclasses of opioids have followed in procession. We start with prescription pills. These are the natural and semi-synthetic opioids that we use to treat pain. They are a modern panacea, except when excessively used. As we see here, there was a 20-year period or 15-year period of rising overdose due to these pills. And I'll explain the reasons for that in a minute. They're probably well known to all of you. But then unfortunately, there was a spillover effect where wave 2 came in, overdoses due to diacetylmorphine, an illicit substance called heroin, picking up around 2008, but really picking up in 2011, 2012, 2013, 2014, as we see here by the second set of arrows. And then the deadliest wave yet, a spillover effect to synthetic opioids. Now fentanyl is a medication, but in this context, this is mostly illicitly manufactured and illicitly used fentanyl and fentanyl analogs. And you'll hear more about this third wave. This third wave is still driving the overdose crisis, as we see here. Those two slides are a little bit dated, but I use them because they graphically show the metaphors really well. But here I've pulled from the Centers for Disease Control website the latest overdose data. This is as of December 2020. I just pulled it 2 days ago. And look at that top curve. Look at that black curve. Okay, these are deaths due to opioids, all classes. We see that they're almost getting to 70,000 Americans dying of opioid overdose in 2020. We also see what's driving that. The curve just below that, that gold curve, is deaths due to the synthetic opioids such as fentanyl and fentanyl analogs. That is what's currently driving the opioid overdose crisis. We see that those lines have continually gone up since the fentanyl crisis started around 2014, with a steep increase as of 2019 and 2020. Now, you heard me correctly that the steep increase in overdose deaths started prior to COVID. Now, COVID certainly drove it even higher, but the rate of increase, what we call an attack curve, started prior to COVID, and no end in sight. So let's dissect each one of these waves just very briefly to describe the supply and demand forces. There were, as we all know, a tremendous increase in the availability and the supply of prescription opioids. These are the pain pills, both through excessive marketing from the manufacturers and distributors, but also the excessive prescribing from the doctors. We see here a tripling of opioid prescriptions over the last decade and a half, but then a leveling off and a decline. Now, people got really concerned about this in the late 2000s and said, hey, what's going on? Why so many pills, and why all these hospitalizations, ER visits, and deaths due to pills? We have a real problem here. So we started putting in controls. And what were those? Well, if your theory was that excess prescribing was the problem, then you put out prescribing guidelines, as the CDC did. If the problem is doctor shopping, patients going from one doctor to another in order to get extra pills, then you put in prescription drug monitoring programs, PDMPs. If the problem is pill mills, which is the fully illicit practice of writing prescriptions for pain pills, then you call in the DEA. If it's diversion, you look at disposal programs. If it's illicit use, that is crushing the pills and snorting or injecting them, you turn to the FDA and say, can you encourage pharma to create abuse deterrent formulations? And of course, one thing I didn't put in the slide is that there's also litigation against suppliers now for either pulling the wool over our eyes or just being blindsided and ignoring the problem as it got worse. The goal, of course, is to cut down the supply of the pills to decrease illicit use. The question, of course, is it working? And we see that, yeah, there was a decrease, a leveling off and a curve down in terms of prescribing. And this has continued to happen. We're about 45% below the heights of prescribing in the late 2000s. And we saw some initial good news where there was a decline in opioid pill overdose hospitalizations. That's the curve to the right. They're kind of parallel. So this was good news and was encouraging that our policies were working. And we see here, there was also a leveling off in mortality due to the subclass of drugs called semi-synthetics. That's the prescription drugs. Unfortunately, we also know from this slide that around the same time, in the early 2010s, that heroin use, number of users, the amount of use, and the consequences of that use, including hospitalizations and mortality, ironically, paradoxically, picked up. So in public health, we like to think of the big picture, if you will. We think about drug epidemics as having supply and demand sides to them. This is really public policy. We also think of upstream or root causes. And one of the things that some colleagues and I, Nabarun Dasgupta, Leo Bolesky, and I, we wrote a paper examining, well, what if it's not just about excess prescribing? What if it's about patient demand? And the question we went into writing this essay, and this is a very highly cited paper, a little bit of a kind of a feat for a public health paper to get so much attention. We simply asked the question, what brought patients in to see the provider in the first place? And I'm giving you all these little tidbits that I'll say with each one of them, like, well, this could be an hour talk in and of itself. I'm just going to give you one slide. Here we have a survey that's done in multiple countries, looking at what proportion of the population states they have physical pain in the past month on an often or very often basis. And if we were a live audience, I wouldn't show the slide and I'd say, what would you say? What would you say? How would you guess? And I asked the audience, how would you guess, what proportion of Americans claim to be in physical pain often or very often in the past month? The answer, according to this one survey, is the bottom line there. The #1 ranked country in the world in terms of often pain, the United States, 34% of the population claiming to be in physical pain often or very often on a monthly basis. That's disturbing, that's outrageous, and guess what? That helped drive the opioid crisis. Just one slide, sorry, I could present many more to support the argument. My point, though, is that we then took the supply of opioid pills and constrained them. We then brought in all of our public policy notions and said we need PDMPs, we need prescribing guidelines, we need to stop the flow of the illicit use of prescription pills. But we ignored the balloon effects. What are the balloon effects? People transitioning to heroin. My team and I hit this at the right moment in time, did a bunch of exploratory research, mostly ethnographic and qualitative, talking to people who were affected by addiction to opioids, and documented transitions from pills to heroin. We did both qualitatively, as I just described, but also in quantitative statistical measures, showing that these two waves were intertwined. We look at other people's data, like Theodore Cicero, writing a tremendous paper in JAMA Psychiatry a bunch of years ago. And what he looked at was he had a lot of data from people entering treatment for heroin. And he asked them, when you started the process that led to your addiction to heroin, what did you start with? What opioids? And they mentioned, a bunch of different pills, Dilaudid, hydrocodone, or did you start with heroin? Now, if you came in, you said, I started my heroin career, if you will, in the 1960s or 70s, the majority of people said, I started with heroin. They might have done some other drug, but not an opioid prior to using heroin. If you ask people in the 2000s, 75% of them started with prescription pills and then transitioned to heroin as the supply got cut off. That's a pretty damning statistic. So, graphic here, photo taken in Philadelphia, the intertwining of the pill side of the equation and the heroin side of the equation. These are intertwined epidemics. So in addition to people transitioning from pills to heroin, we also have a more dangerous heroin supply. Again, very briefly, I could present a number of slides here to support an argument that heroin is becoming more dangerous, but I will say the supply is up. Now, if you're a supply sider in the drug policy argument, you say, well, Dr. Ciccarone, that's what caused the increase in use, is that supply got more robust. But if you get onto the nuance of it, I argue the opposite, that supply responded to demand. Either way, supply is up And these are seizure data. We like to think, well, seizures are good. We're taking drugs off the street. But in drug policy, we have evidence supported by 40 years of data that seizures just are parallel to supply, that the rate of seizure remains more or less constant, and that if seizures are going up, it means supply is better. The other way in which heroin has become more dangerous is by being adulterated, cut, laced, whatever phrase you want to use, with fentanyl or fentanyl analogs. Now, this substance, as I mentioned before, is a synthetic opioid. Has nothing to do with the poppy plant. It's fully made in the lab. It's meant to mimic the natural opioids. But the fentanyl we're seeing on American streets right now is not pharmaceutical diversion. It's an illicitly manufactured and distributed product. It's integrated into the heroin supply, meaning that most places, and we've documented this by doing research in a number of cities around the United States, that it's sold as heroin. It's not sold as fentanyl. It's not the new in-demand drug. It's a drug that's been laced into or adulterating heroin. It's much stronger than heroin, which is why it's so problematic in terms of overdose. And I'll just leave it all at that. In addition to mother fentanyl, there are now hundreds of chemical cousins, or what we call analogs of fentanyl, new ones coming out every month. The big baddie are carfentanil and a couple of analogs that are like carfentanil. They're meant for large animals, not for humans. They're super, super potent and thus super dangerous. Where's the fentanyl coming from? It's coming mostly from China, and we've worked out bilateral agreements in terms of cutting off supply. They have yet to help, unfortunately. Those agreements started around 2018, and we're still waiting to see the effects of them. But the supply comes in through largely in a large volume form through Mexican trafficking, then cut into heroin for the US heroin market, which is mostly at this point fed by Mexican CTOs, criminal trafficking organizations. A small volume of high purity product comes in through direct sales, and that's through the dark web, straight into the United States, through the Postal Service and through other shipping mechanisms. And an unknown amount of flow. And this is a current mystery, but there is documentation of more than minor flow of fentanyl into Canada, where it's being pressed into high quality mimics of prescription pills. And we're going to be reading more about the counterfeit pill problem as it concerns fentanyl over the next months to years. Largely the problem up until the last couple of years has been a regional problem of the Midwest down to Appalachia, up along the Eastern Seaboard to New England. That's changing. This data is from December 2020. The map of the United States below shows the percent increase in drug overdose deaths from 1 year prior to current. And we see that it's more or less even across the country. And that implies two things, which again, I would have to spend a lot of time describing in detail, but I won't. That fentanyl has been moving westward, and other serious drugs like methamphetamine are going eastward, particularly to places that they haven't been before, like New England. But bottom line is, overdose is a fully national problem at this point. Our streets are awash in pills, liquids, powders, and injectable substances. This is a mural from the south side of Chicago. So now to try to bring this back to a clinical level, to a personal level, to a neuroscience level, let's talk about addiction and why it is that there was this spillover effect from pills to heroin to fentanyl, how we make sense of it from a clinical perspective. We have in our minds sort of a public perception, a metaphor, if you will, of what a heroin user looks like. It's someone like this, who's in this case is under an overpass in an encampment. He's of low social status. He's injecting through his clothing, doesn't really care very much. That's how far his addiction has gone. What we don't think about is someone like this, Philip Seymour Hoffman, successful, white, I assume wealthy, I don't really know, who pretty much at a pinnacle of his career returns to heroin use, overdoses, and dies. So bottom line here, and this I will substantiate in a number of slides coming up next, addiction, or the disease we call substance use disorder, or in the specific case here, opioid use disorder, is a universal problem. It may cluster in certain places from time to time, inner city, 1970s, and now more rural America in the current era. But it's a universal human condition. Our theory of addiction has changed. For a long time, we held on to a moralistic view of addiction. Then, in a uniquely American way, we said, well, it's about choice. People are just making bad choices. Increasingly so, we see it as a disease, as a brain disease, where there may have been some choice early on in the process, or some life circumstance that pushed someone in a certain direction. But once the disease gets hold, starts to change the neurocircuitry, the hard wiring, if you will, it becomes a brain disease. Increasing evidence for that. We know that substance use disorders do cluster in families. There's best evidence is for alcohol use disorder, alcohol addiction, where about 60% of the likelihood of a sibling having it is genetic. This is coming from twin studies. We do also believe that this is true for the other drugs. We just don't have as much good data as we do for alcohol. Of course, along the way, there's also environmental cueing. One of the ways we see this is in the level of response. So for example, in my clinical practice, if I have a teenager or a young adult who's come in, I have them describe, just like I would do ethnographically, what they like about the drug. And you'll hear these incredible romantic stories of how much, what their first use was and how wonderful it was, how much they love the drug. And that to me as a clinician is a risk sign, right? That level of response. A lot of us have tried various substances along the way, but we didn't necessarily have that level of response that a young person who then develops an addiction has. And we have to focus on that there's certain levels of reinforcement, both social, but also neurologically, that are going on that lead someone down a more injurious path with an illicit substance. If we look at some definitions, they give us some clues. NIDA calls opioid use disorder a complex, chronic, and potentially fatal brain disease. The Diagnostic Statistical Manual, which is what psychiatry uses to make all of their diagnoses, describes it as a neurobehavioral syndrome characterized by the compulsive seeking or use of an opioid despite adverse social, psychological, or physical consequences. I'm going to highlight this. This is the difference between someone who uses a drug without consequence and therefore without a label, without a medical diagnosis, and one who does acquire the medical diagnosis, and that is use despite adverse consequences. We focus on that. Those consequences could be medical, they could also be legal or social. And we focus on that in our diagnostic criteria. In terms of neuroscience, this is my key slide. It's not anywhere near as fancy as some of the slides that you've seen earlier today, but metaphorically, it tells us a lot. So in the brain system, there's a fine balance in the areas that are involved with reward, motivation, learning and memory, and inhibitory control. Let's take a metaphor now. Okay, when I eat chocolate cake, I really like it, particularly with a glass of cold milk, right? Or maybe some coffee, right? That has given me a lot of reward, and hopefully it's tied in with a behavioral reward. Like I went for a nice hike that day and I deserve that chocolate cake, right? So that leads to motivation. It's like, if I want chocolate cake with coffee or milk, I should go on that hike. I should take good care of myself, exercise regularly, and then I deserve that treat. We learn these processes, we put them into our memory. Maybe they even come from childhood memories of being rewarded with chocolate cake, right? But then as we grow older, we also bring in our frontal lobes and have inhibitory control that says, I can't have chocolate cake all the time. It'll increase my waistline, it'll be bad for my blood sugar, et cetera, et cetera, et cetera, bad for my teeth. So I'll only do it under certain circumstances. And that is maturity. And that is a well-functioning brain, if you will, right? And we all have our own sort of compass around this. What happens in the disease of addiction is that inhibitory control, which is in the frontal lobes, you see that what we call the executive functioning area here, up in the front forebrain, if they will, that helps us with inhibitory control. That's our guide to say when a behavior is appropriate or not appropriate. The problem in the disease of addiction is that the reward center starts to take over, and the pleasure versus risk ratio gets thrown out of proportion, such that we want the reward, we like the reward becomes more salient than other things in our life, including all the way to the point of, in that metaphoric picture I showed earlier, of the guy who's now homeless, living in an encampment under a bridge, et cetera, not taking good care of ourselves, right? Because the reward center and what we've learned from that in a kind of more primitive, more animalistic way is taking over the other more advanced functions of the brain, like inhibitory control or other salient motivations. Bottom line, addiction uses that part of our brain which is about survival. It's tapping into the reward system, is a very primitive system in the brain. It is telling us that we tend to think of it as the 4 Fs, the feeding, the fighting, the fleeing, and I'll leave the 4th F up to your imagination, right? It's about survival, and highly rewarding drugs like opioids tap into that center so that those become our way to survive in the person who suffers from the disease of addiction. Now, of course, along the way, there's other environmental parts that are tapping in. It might be some social cueing, some reinforcement from peers or from life circumstance. Maybe life is full of pain and seeking a pain reliever like an opioid. And I don't just mean physical pain, I could mean emotional suffering as well, may lead us to a mellowing drug like alcohol or an opioid. We've certainly seen alcohol use go up during the COVID era. It's been very stressful, very isolating for people. And we know both the number of people drinking and the amount being drunk by any given individual who is a drinker. I know a lot of people don't drink, has gone up during the 2020s, right? And that's emotional soothing. We do also know that along the way, there's a phenomenon called dependence and tolerance, where our ability to resist escalating our particular substance use, our ability to keep that under control goes down, and therefore use goes up. It may become compulsive. And then one of the clinical cues that we look for this, again, if I'm interviewing someone, is asking them about craving. How much does the drug enter your imagination? How much does it enter the first things you think about on a given day? How much do you crave it? Because I understand that as people's craving goes up, so will their compulsive use. And what I'm on guard for in the treatment setting is to look for that craving as a symptom of potential relapse and try to do things to try to prevent relapse. We do understand that substance use disorders are a chronic relapsing condition. I almost expect no matter who the person is that comes into my office, that they will at some point relapse, right? Because it is part of the syndrome. One too many times, Frank lets his mind wander. He's playing with live wires there. So fortunately, for opiate use disorder, for this brain addiction that we sort of have a moderately good understanding of the brain mechanisms, moderately good understanding of the disease pathology, we do have treatments for it. The main treatment is medications for opiate use disorder. I should actually change OAT to MOUD is what we call it now, medications for opiate use disorder. Methadone is one we've had for 50 years, fantastic evidence base for it. Buprenorphine, growing evidence base for it. My particular favorite for using because it keeps people highly functional and gets the job done. It reduces craving, reduces the dysfunction related to the drug use, etc. We also have naltrexone XR, which is growing in favorability as its evidence base grows. This is an injectable monthly treatment. I don't have a slide to explain them in more details. The difference between the top two and the bottom one, the top two are agonists, and that is they feed the center that is craving drug and therefore satiates it. Naltrexone is a blocker. And for some people, it works wonderfully. They do well having their opioid center blocked, and some people don't do well. Some people really it leads to further craving and dysphoria. So it's all needs to be tailored to the person then. Why do we use medications? Well, if we think of this as a brain disease, it's not much different than any other organ disease, if you will. So for diabetes, we have a disease of the pancreas where there's either insufficient insulin production or insulin resistance, and we either bolster insulin by giving insulin, or we try to decrease insulin resistance to lower blood sugars and lower the morbidity due to diabetes. It's a complex disorder. Substance use disorder is just like diabetes. It requires a comprehensive approach. Just because I have a patient who suffers from diabetes doesn't mean they're immediately going to understand the need for insulin or the need for daily blood sugar measurements and daily injections of insulin. They need to be coached. They need to be supported, right? We use an entire clinical safety net team, if you will, in order to support a person newly diagnosed with diabetes. Same thing with substance use disorder. It needs a psychological approach, a social support approach, and if you believe in the brain disease idea, medication. Meds help stabilize in the short term, while the psychosocial counseling works on the medium to long term, right? And the latest data says, this is almost shocking to a lot of people, that treatment for somebody who qualifies for the disease of a use disorder needs to go on for 5 years, not 6 months. Most of our programs say, oh, I'm going to go to rehab for 6 months, right? That's just a starter. 5 years of treatment. Oh, here's the slide I was looking for. So the difference between agonists and antagonists. So if we look on the left there, the agonist binds to, this is a model of the of a neuron with a receptor there that's being stimulated. The agonist binds that neurological receptor and activates it, whether that's a pain center or whether it's a pleasure center. It does its job. The antagonist goes to that same receptor and blocks it, so that if you were then to inject heroin, you don't get any effect. If you look on the right here, we see the purple lines at the bottom. If somebody were to inject or use an opioid, they would get no effect, ... across the bottom there, with an antagonist like naltrexone. With a full agonist like methadone, they actually get feeling from that drug, right? They will feel, in the early days, they might feel a little bit high. In the later days, they just feel like satiated in terms of their cravings and withdrawal symptoms, but they get full effect. The beauty of buprenorphine is that it's a partial agonist, so it works partly as a blocker. So if you use heroin on top of buprenorphine, it gets blocked, believe it or not. And at the same time gives people a partial satiation of what they need in terms of pleasure and pain, pain blocking and pleasure seeking. Our treatments are effective. It's not just substituting one drug for another. It's actually giving a stabilization effect and perhaps even improvements in neuroadaptation. One of the things we look for in the clinical setting is retention and treatment. Again, people are going to relapse. If I can retain them even through a relapse, okay, I've been successful as a doctor. We know that retention time in treatment, retention and treatment is correlated strongly with long-term success. We also see increases in functioning. We see decreases in harms, decrease in illicit use. This is across hundreds of studies over multiple decades. Decreases in illicit use, decreases overall overdose mortality, decreases HIV and hepatitis C transmission. Why? Because they've left the needle behind. Increases social functioning, decreases illicit or poorly adaptive social functioning like criminal activity. When thinking about psychosocial interventions, the current model is we use medications first for opiate use disorder. That might not be true for other substances, but for opiate use disorder, we use medications first and then layer in for the medium and long term psychosocial interventions. If we think about, if we compare two of our favorite treatments, methadone versus buprenorphine, methadone has a slight edge in terms of retention to treatment. It is a stronger drug. But if we think about effectiveness across the population, methadone requires a special clinic. It's highly stigmatized. People don't want to go to methadone, just like a person newly diagnosed with diabetes doesn't want insulin, right? They need a lot of coaching to get in there. Buprenorphine is more easily adopted. You treat it at the primary care level. You don't need a specialist necessarily. It's very safe. Of course, because it's prescribed widely, we are concerned about diversion. The bottom line is both of these medications are still underutilized. I'm going to skip this slide, talking about naltrexone. If there's questions, we can go back to that slide. So just to end, this triple wave, as I've described it, of opioid overdose, one wave, a tsunami on top of the one before it, is unprecedented. It led to a change in the US death rate prior to COVID. COVID now is accelerating it. There's momentum behind it. There still is momentum behind it, despite being 4 or 5 years into fentanyl and more, 6, 7 years into a fentanyl epidemic, it still goes on. We still lack a coordinated, robust response. We're working on it. I expect the new administration to take a bold approach to this. And on a public level, we suffer a lot from stigma and shame. We need a comprehensive solution with both supply reduction on the fentanyl side, but also demand reduction that includes treatment. We need to rebuild our communities to make them more resilient to wave upon wave of drug problems. And we need harm reduction. I'm going to skip that slide and just end with, this is an epidemic of crisis proportion. It's also a crisis with epic opportunity. We brought the HIV epidemic to a manageable level through treatment and prevention. The same thing will work for this epidemic. And with that, I'll end with my acknowledgements. Thank you all for your kind attention and open it up for questions.
Yes, indeed. Thank you very much, Dr. Cicciarone. We are going to be running out of time pretty soon. So let me do a couple things. We may not go to the breakout groups, but let me ask some quick questions, some of which have already appeared. I guess the two that I have myself, if I can take advantage briefly, and the first one would probably require a whole presentation. I know we discussed, you and I, before this, the question that I had in my mind, maybe many other people have, of, are people sort of predisposed to become addicts in terms of the structure or the functioning of their brains, or is it that the plasticity of the brain is altered because they use drugs and therefore they just sort of dig themselves into a hole deeper and deeper? I think you sort of alluded to that, but perhaps you could quickly answer that one. Secondly, this is more for our sort of judge and lawyer types that are participating today, including myself. Some of what you've said suggests that perhaps our justice system, to the extent it finds itself having to deal with people who have addiction and who are accused of doing bad things, possibly in relation to that addiction, but anyway, in conjunction in some fashion, should be able to perhaps do more to get people into programs, perhaps require them to get into treatment programs and to use some of the medications that you've indicated. On the other hand, I suppose there'd be something of a reluctance in our society, given the way that, for example, in the old Soviet Union, certain kinds of medical or psychological facilities were allegedly abused to, crack down on political dissent. So
yes, let me get into that.
How do we want to manage both those things off the bat?
Yeah. So Elaine, you bring up two hot button issues. So the first one is it's complex, right? So I'm actually stick to our parallel metaphor, which is diabetes, right? It's a complex interaction between genetic influences and environmental influences, right? There are some people where diabetes literally runs in the family, right? And they need to work hard to avoid the genetic predisposition they have. On the other hand, we do also know that obesity, sedentary lifestyle, certain food choices will feed diabetes, whether you have a familiar risk for it or not, right? And so the same thing with addiction, right? There are people who clearly have very strong genetic predisposition. There are also people who have very strong environmental cueing in their life in terms of the pressures, sadness, the strain that they've been under, usually as young people, seeking relief through drugs. Now, if they have that plus the genetic predisposition, watch out, okay? The thing is, right, we don't lock up diabetics because they eat too much chocolate cake, right? We treat them medically. Now, I know that I'm biased. I'm a doctor, MD, but my point is we underutilize treatment. The judicial system should help guide people earlier, right? If we let people go 10 years into a heroin habit, 10 years into a criminal habit related to a drug habit, right? We have failed as a society. Why didn't we pick them up in year 1 or year 3, right? Coercive treatment, by the way, does not work. Study after study shows, I mean, we think, oh, why not? They've lost control of their inhibitory function. So why don't we act like their superego and put the control back in there? It just doesn't work. As soon as they leave, they're angrier and more fed up, and they go right back to satiation with illicit substances. We can use a soft paternalism, right? And that's what I would like to see out of our drug courts, where the superego comes in terms of a humanistic and moderated response that guides people, maybe strongly, maybe with a firm hand, right, in the right direction. Some of my harm reduction colleagues would hate me for saying that, but I do think a soft paternalism would work.
Okay. Allow me to get to some of the, in case you haven't seen them, Doctor, in the chat.
There's some good chats there, yeah. So let me address the meth question away. So
absolutely,
yes, we are currently in the 4th wave. I just published a paper a couple months ago describing how the meth phenomena, not just meth, but stimulants, cocaine and methamphetamine, are leading to a 4th wave of overdose deaths. It is intertwined with the fentanyl wave, right? At least half of methamphetamine involved deaths involve opioids as well. What's currently not understood is what's driving the half of methamphetamine deaths that have nothing to do with opioids, and that's an open question. The meth has become stronger, it's become pure, it's more D-isomer, which has more cardiovascular and CNS problem associated, but we're currently analyzing, diving into what's going on with stimulant use disorder. But I do recognize it's taken over the country. Meth has moved into New England, which is never seen before. We wrote a paper on that, and it's a highly problematic and highly potent new form of meth that's coming in.
If I may, from Judge Lamar, moving back up on the list, She said, we have young people who admit to crushing and snorting their, and forgive my pronunciation, buprenorphine. Does this produce a heroin-like high? And does that, I guess, affect your recommendations about its further utilization? You did mention diversion. Thank you.
Yes, so buprenorphine is highly diverted. Most studies, including my own, show that it's, believe it or not, it's actually being used appropriately. People are using it to ameliorate their heroin habit. They're trying to avoid fentanyl. People are very scared of it. Believe it or not, there's this myth that people always run to the harshest and strongest drug. Well, that has been blown up with fentanyl. Fentanyl is actually too strong. Most people recognize that. If you look at population surveys at this point, maybe about 30% of current heroin/fentanyl users on the East Coast prefer fentanyl. The other 2/3 do not. And that 30% kind of shocks me because most of the people that I talked to in the early days were quite afraid of it. So buprenorphine comes in, it's being sold and sort of illicitly sold to friends or given away to friends and family and community members as a way to help. And we may not like that, right? We don't like our medications being diverted. We think that sort of adds to the problem. It's actually hard to believe. It's actually probably helping the problem. If you use buprenorphine, even intermittently, it's going to lower your overdose risk. So if our North Star, as Chauncey Parker of New York, New Jersey, HIDA says, if our North Star is to decrease deaths, then we should, as some progressive prosecutors have looked at it, we should become more tolerant to buprenorphine diversion. Again, I know that sounds a bit avant-garde or risque, but buprenorphine is a helpful drug, even in the illicit use of it. Now, I know people are snorting and injecting it. I've documented this in my own studies. They're actually not getting any extra benefit out of it. They're doing it just simply out of habit. They think, oh, well, if it does this when I put it under my tongue like I'm supposed to, what happens if I inject it? Most of them tell us it doesn't do anything different. It still blocks the effect. If they try to use fentanyl later that day, it's going to block it. They don't get extra high because they snorted it or injected it. They just did it because the behaviors of the drug use sometimes go along with the well-worn tropes that they've been doing for years now. They think that all drugs should be injected. The buprenorphine still helps them. Now, should we do better than that? Sure. We should always guide people toward care, toward stable use of buprenorphine as opposed to episodic use of buprenorphine. But the problem is we're caught in a political crunch here, right? The people who have eagle eyes for the diversion are coming from the same counties, states, locales that are saying, oh, we don't really like buprenorphine, so let's look for the harms of it, right? And then they clamp down more. Well, guess what? That just adds to the illicit diversion and use of it. People go to the private sector, they pay extra for the buprenorphine as opposed to getting it for free or reduced cost at the public sector, and then they have to make up their money. So of course they sell part of their buprenorphine. That we've documented, right? So if you want to cut down on the illicit use of it, make it actually more available and encourage people, incentivize folks to come into clinics and be treated appropriately, even if they relapse, even if they go 1 month on, 1 month off. Any buprenorphine is better than the high risk environment of the fentanyl world that we're in right now.
Well, I was just going to ask, and then I'll let my colleague Margaret perhaps ask the last question if there's still one, and then we'll wrap things up. Speaking about fentanyl, and in the interest of full disclosure, I used to be a Foreign Service officer working at the Department of State. So frankly, what comes out of China was of some concern. My question, I guess, is there any indication yet that, like, we've seen a little bit of a curve downward with respect to some of the opioids, that fentanyl is beginning to plateau at all, or did I miss a slide? Forgive me. There is not. Okay, so we saw a brief respite in 2018 in terms of the flattening out of the overall mostly 2018, early 2019 in terms of flattening out of the curve. And people have a number of theories around that. If you're a supply side, you say, well, it's the reduction of
pill prescribing, I checked that one off. I agree that we saw some effect of the 40% decline in opioid prescribing. Some people say, well, that was the year that we, got hard hitting with China, and they got, full fentanyl analog ban going. I disagree with that because it was too early for public policy to take it. And China doesn't have the regulated environment we have. So even if they outlaw all fentanyl in China, it's really hard to regulate small production in the back of some huge factory out in rural China, right? They simply don't have the regulatory capacity to go detect and shut down all the fentanyl labs. And the third argument was that carfentanil picked up in 2017, and carfentanil, which is super deadly, everywhere it goes, it leads to a death wave, simply went away in 2018, and nobody knows why. But maybe because it's just a ridiculous drug. It didn't make any sense at the street level, so the dealers stopped slinging it. I like that theory a lot too, that carfentanil simply went away for a year or so, and that led to a little dip in the opioid supply. But the bottom line is, as of December of 2020, and as of any data that I hear now from state, county health departments, right, the fentanyl epidemic keeps growing. And it's commingled now with a fentanyl epidemic.
Well, thank you very much, Dr. Ciccarone. Margaret, did you have any thoughts, last thoughts, questions? And then I'll do some wrapping up too.
Yes, I think we just had one question left from the chat regarding mortality rate. We saw on one of your early slides, the mortality rate, of course, highest, for the Spanish flu. And Judge Stein asked, why didn't the rate go down, mortality rate go down significantly after the Spanish flu? Can you speak to that?
Well, it did. I mean, it was a spike up and it came down, and then there were some rumblings for the next 10 years or so. If that's it, we're talking about why didn't it go down faster? This is the 1920s. There's still a highly disparate environment in the United States. There's still a tremendous amount of rural poverty. We don't have universal access to safe water, to malaria is still a problem in the 1920s. There's a whole bunch of things that are still going on in the development of America in the 1920s. We think of the 1920s as being a boom time where, the Great Gatsby and all that, but that was just a small segment of America. There's still a big part of America that was under tremendous environmental pressure due to classic childhood diseases and other diseases related to poverty or environment. So it takes decades to solve these things. And you see what happens next over 70, 80 years is a steady decline as we develop. So the curve makes utter sense to me. The question is, what happens now with COVID, right? We've yet to see a well, I think we're starting to see now. I think if that data was included 2021 data, we would see a leveling off of the COVID curve. And that's due to the fact that, about half of Americans are vaccinated. But we still obviously have work to go there.
Absolutely. All right, well, I'm going to give the floor back to Alain Norman in just a moment. I want to thank our four instructors, starting with Daniel Ciccarone from University of California, San Francisco, Craig Stark, also coming from California, University of California at Irvine, Daniel Klaw from University of Michigan Medical School, and then Leonard White joining us from Duke. On behalf of all of us at the National Center for State Courts, it's a pleasure to partner with AAAS on this session. And I give the floor back to Alain for some closing remarks.
Well, thank you very much, Margaret. Basically, you took the words right out of my mouth. I wanted to thank our wonderful presenters and you and the center for cooperating with us. And I wanted to thank the Dana Foundation for the financial support that they provided for this ongoing series of neuroscience and the law. We've been doing it for several years. Obviously, recently we've been doing it via webinar rather than in person. We're hoping next year to do it in person, and that way we will be able to meet in addition to having the breakout rooms that we had this year, which we hope you all enjoyed and found fruitful. In fact, we would appreciate feedback from you. One sort of question that has popped up more than once, which I wanted to get to too, is accessing the recording of this event. Basically, it should be available to those who have registered and upon request. So we'll be making those available once the video has been further processed, and it'll be made available through that means. Again, thank you all for your participation. Thank you to all you judges who are out there. If you have follow-up questions or comments, we're certainly open to it. And with that, I'll leave you to get back to your lives. Thank you very, very much, all of you.
Thank you, everyone.